We are going to get started here. Folks can wrap up conversation.
Continue.
All right. Welcome, everyone. Looks like everyone got lunch. Happy to see you all here. Hope travels were smooth. Thanks again for being here. I'm going to just go over some housekeeping stuff and get us started. So as we get started, couple logistics. Bathrooms, restrooms, just outside the door, down the hall to your right. Take care of your needs whenever you need to do that. There's some coffee here in the corner. There's also tea, coffee, water outside. If you have any questions about where things are, just grab one of us. If at some point, for some reason, you need to step outside to have a conversation, take a call, there's a couple of health huddles immediately across the hall. Grab one of those, shut the door, people will leave you alone. Hopefully you don't have to do that. We'd love you to stay here the whole time, but that's there if you need it. And a reminder that this meeting's being live streamed. So when you speak, please use the mics. When others are speaking, try to keep conversation to a minimum because sometimes the mics pick up other conversations. So just a reminder, use mics when talking and try to keep other conversation to a minimum. So as we get started here, whoops, all right, there we go. So we have a couple of folks online. We've got a team helping us include them in the conversation as much as we can. Folks online, thanks for tuning in. Use chat if you need to get a hold of us, and you'll be in breakouts throughout the day. Reminder about it being recorded and made available later. And any technical questions for those online, find Carson and reach out to her. So here's our agenda for today. We are in the middle of welcome and get lunch. Hope you all got lunch. When you're done eating, just leave it there. You don't need to go find the trash, just scoot it to the side. One of our team members will pick it up so that we can just keep going. We've got a lot of ground to cover. We're gonna start with sort of level setting, some reminders of what we've done thus far, all the feedback we've heard. We've got a new member to welcome. We'll do some introductions. Then we're gonna talk about vision. If you've picked up your packet and peeked, you've probably seen some of where we're going today, but we wanna hear what your vision is for this group. And then we're gonna do some RFP feedback, talk about use cases for upcoming years and upcoming work. You'll have one break at 2 o'clock. So if you need to answer some emails, you can hold it till 2, that'd be great. Then we're gonna spend the rest of the time working on the work plan and we'll be out of here by 4 o'clock. All right. I mentioned the packet. Does everyone have one of these? If not, raise your hands. Okay, great. So in your packet, we will tell you when you need to use these things, but you should have an agenda. There's also an agenda at your table if you need a quick reference. You also should have on the right side a vision document. You will use this to craft your visions, and we will be picking this up so we can gather that and process it. You also have a work plan note taker. This is what we'll be using at the end of the day. So please keep these documents handy, but feel free to use them as they are helpful. Okay, now for a little bit of fun introductions. I know we have done introductions pretty much every meeting. We've got a new member though, and we also want, you guys made the effort to be here in person, and we want to build some connection, facilitate some collaboration, because you all are gonna do a lot of work together. So we want name, role, and a fun little connector question is think back to your childhood and what was a technology that you thought this tech is amazing. I love this tech. So I'm gonna start up here with my team, and Sheena will start and introduce. Sheena, your name, role, and the tech that you loved.
I didn't think that I was participating, but let me think about this. I'm Sheena, and you've all seen me before on our virtual meetings. I help support the facilitation of the work group, and I am a senior analyst and strategy team leader here at KHI. I lead the access to care work. Let me think. I think my favorite technology had to be my Walkman that you like the tapes when I could listen to it and take walks, and that was really cool.
Hello, everyone. My name is Shelby Rowell. I'm an analyst at the Kansas Health Institute, and I work on our artificial intelligence portfolio, as well as all things rural health and state health policy. So I think my favorite technology from my childhood, my first kind of video game was a Game Boy Color, and I had a Lion King game that I really enjoyed. So
Thank you both. Kristen, you wanna keep us going? Name, organization, and your favorite tech.
Kristen Ebert. I'm with the Center for Rural Health Innovation.
okay.
Kristen Ebert with the Center for Rural Health Innovation. And I was going to say Walkman, but since Sheena already did, I will say call waiting. It revolutionized knowing how you needed to hang up faster.
Thank you.
I'm Marty Ross with the UKHS Care Collaborative Association. We're the connector of this group to KDHE, and I'm going to show my age. It was a TV remote control.
Excuse me, Scott Rollletter, CTO with Great Plains South Alliance. We actually, my mom, and working with Tupperware at the time, she got a microwave oven. Was in like 1976. It was like one of the first microwave ovens. It actually, the fan would stay on when you open the door, so it sounded like it was still running. And my girlfriend later in life was like, looked at us like when we stuck our hand in there thinking it was going to get cooked off because of the microwaves. But anyway.
Good afternoon. I'm Chad Austin, President and CEO of the Kansas Hospital Association. Similar to what's been mentioned, probably some video games, and maybe the first one that I used was the Atari, was kind of the game that my friends would come over and play.
My name is Alan Wamser. I'm the Director of Cybersecurity and Infrastructure at Hayes Medical Center, and I will probably just go with my very first computer, which would have been the Commodore 64 and a game called Pole Position. So.
That's the question. How about now? All right. Audible? Try it now. Okay. I'll try again. Aaron Wooten from Stormont Vale, a 56K modem, because then you could actually play games with people outside.
PK Gugnani, physician, Community Health Center, Southeast Kansas, CMIO, CIO. Favorite childhood technology? There's so many. Yeah, one is hard. We'll go with one that people may or may not remember. It's called Speak and Spell, which I sadly still have.
Hi, Michelle Ponce. I'm with the Association of Community Mental Health Centers, and I'm going to go with the Nintendo.
Good afternoon, everybody. My name is Leland Bardsley. I am the HIE project manager with KDHE. And I'm gonna steal yours. It was also Nintendo for me.
Awesome. Thanks. Let's come
PowerPad.
There we go. Hi, Dick Flanagan, lead digital health KC. I might be one of the older people in this room, so I was going to say television, but since you said remote, I'm going to say the Polaroid Swinger camera, which did instant black and white photos that were very small, and I think it influenced my interest in photography. So something a little different than the rest.
Nathan Gauls, I'm at University Health in Kansas City. I'm the Chief Population Health Officer for it's the new title, so sorry. And I'm an orthopedic surgeon. Technology, I was going to say 8-bit Nintendo, but it's been said twice. So what I recall very distinctly is my father had a cassette player in his vehicle, and there was this technology where you could fast forward through a song and it would stop at the space and then start the new song again. I thought that was the coolest thing ever.
I am Sarah Good. I am the CEO of KFMC Health Improvement Partners, a not-for-profit consulting organization based here in Topeka. And I had several in my mind, and most of them have been said, but I'm going to go with caller ID. I don't like to talk on the phone, so if I don't have to, that was a godsend.
I'm James Stowe, the President and CEO of the Center for Practical Bioethics. Thanks for having me join your group. My technology I remember is the color laser printer. You could actually print in your home, and I'd have friends over and we'd select clip art, probably in WordPerfect, and print it out. Pretty amazing technology.
Awesome, thank you. And Doug, we're just doing name, role, and organization.
Okay, put me on the spot here. That's cool.
I know, right into it. A favorite tech from your childhood.
Sure. So I'm Doug Stacy. I'm with Labette Health. I also do Independence Healthcare Center and some work for Wilson Medical Center. Favorite tech. So I'm old. So Atari 2600. I'll go there. So.
Awesome. Thanks. You can leave that mic there. And our last table up here. Who wants to go first? Go ahead, Chris. Grab it.
Okay, Chris Harper from University of Kansas Health System and the Medical Center. I serve as a CIO there. So people mentioned Nintendo, so I'll piggyback off that. Nintendo Power Glove that was featured in a movie 1998 called Wizard, and so that shows how nerdy I am. But that was my favorite childhood technology.
My name is Monty Kaufman. I'm the executive director of Windsor Holdings, which is a long-term care organization. I will rival Dick. I think my favorite childhood technology was Army walkie-talkies that all you could really hear was static. But it was cool to be around the house and talk to your brother.
Hello, everyone. My name is Liz Schaefer. I am the program director at Digital Health KC. And in my house, my favorite technology was our Game Boy, but my friend had the Nintendo. So I'll join 5 or 6 friends in here and say when I was at my friend's house and I could play Nintendo, that was the very best. And that might have been why I wanted to go over to her house so much, just so that I could get on her Nintendo and go to town.
Good morning. I'm Andrew Eichinger. I'm the CETA for the state of Kansas. And I have to go back to an alarm clock I had in elementary school that would talk. It was a Snoopy alarm clock. And I know how it worked only because I had to take it apart and fix it. It had a little record inside of it, and that's how it worked.
Awesome. Well, thank you all for that and for entertaining.
What's yours?
Oh, I'm asked to answer. My name's Wyatt. I'm part of the team here at KHI. I will say I don't know if it's my favorite, but it's a notable point. I remember my first phone, flip phone, and it was one of those like press 3 times for each letter thing. And the first text I sent was to my friend, and all it said was "I can text now," which was not that exciting, but I was excited to have my phone. So that's probably what my favorite tech. I think in 20 years, if we did this, we'd have very different answers. And we're going to spend a lot of time thinking about where tech is going, how to best leverage it, how to use it to help our rural healthcare providers and systems be better. So thanks for, before we zoom forward, stepping back in time and thinking. So the timeline. This is a reminder of where we've been and look forward to where we're going. We are here at our big in-person meeting. We are going to spend some time doing feedback and talking work plan and budget. But before I go forward, I want to give the chance our online folks. See if you are able to unmute and go back to our exercise before we move forward. So sorry. Online, if you're able to come off mute and say name, your organization, and your favorite tech from your childhood.
I can go first. I was started to say good morning, but it's actually afternoon. So good afternoon, everybody. I'm Terry Kennedy. I'm the director of the Health Center Controlled Network at the Community Care Network of Kansas. We're the primary care association for the state. A couple of you said that your answer would age you, but does anybody remember the TRS-80? My parents bought me that when I was in high school as a little computer because I was interested in programming, and that's what I ended up doing early on in my career.
Thank you, Terry. Do we have 2 more folks online? Go ahead.
Hey, this is Robert Fireham. I'm the director of IS at Newman Regional Health. I was all set to be there in person, and then something came up last night, so at least joining virtual. Glad to be with you guys. I'm gonna say tech-wise, something probably off the wall a little bit, but I would say the first fish finder that I was able to use that had an actual screen. It wasn't just the red flashes, but actually had the little pictures of the fish that you could see when you're out fishing. That was probably my favorite thing from when I was a kid, technology.
Awesome. Thank you. And we've got one more, Andrea, online.
Hi, this is Andrea Diaz with the Association of Community Mental Health Centers of Kansas, and I'll probably say an iPad as my favorite technology.
Awesome. Thank you. And thanks for being online, folks. And we will do our best to keep bringing you into the conversation today. So back to where we're at today. Our in-person meeting, we're going to do some final feedback on RFP, use cases, spend quite a bit of time on work plan. Then we have 3 more meetings. We'll go back to virtual, 1 o'clock to 2:30. Hopefully you have those dates. And if you don't have them on your calendar, let us know. But I hope you're all warmed up, ready to go. Reminder, finish eating. When you're done, just set it there and we'll come around and pick it up. And with that, I'm going to turn it over to Shelby, who's going to just set the stage, remind us where we've been before we have you all do lots of engaging and talking and discussing.
Awesome. Thank you, Wyatt. So I will actually come up here. Alrighty, so we wanted to go ahead, and if you've been to our first few meetings, this slide is going to be familiar to you. So when we first started our work, we sent you all a survey and asked, what about this work excites you? And we also discussed this quite a bit on our first meeting through the compass exercise. And what we really wanted to do today is just reorient you guys to this list just so that we can keep it in mind as we go through today's discussions. So a few things that we really want to embody throughout our conversations today: keeping rural Kansans home. So thinking about tech's ability to bring specialty care and primary care directly to communities instead of kind of forcing those long distance travels. Also, ambient AI for clinician burnout. This was a very high area of interest, and of course, our first RFP that we're working on as a group. Next, speed of innovation. So thinking about the pace of digital health innovation, how can that really open opportunities within rural communities? And then finally, keeping the whole person solution in mind as we're kind of building out our work plan and our vision for the ETC. So next, some of the key challenges that was identified through the Compass discussions and also throughout our discussions in our past few meetings. You'll see some of these things come up within the use case conversation that we'll have later today, where hopefully when we're thinking about some of the challenges, we're thinking about how can we provide solutions for these challenges and really making sure that the use cases we're selecting align with the solutions that are needed for rural communities. So a few things that you all identified were financial constraints and sustainability, infrastructure and broadband gaps, EHR fragmentation and integration barriers, workforce adoption challenges, cybersecurity vulnerabilities, as well as reimbursement and payment uncertainties. So again, themes that you'll see throughout today's discussion as well. So finally, our next slide takes a look at some of those solutions and strategies that you all identified early on and throughout our last few meetings. So looking at the near-term priorities, these were things that you all identified as something that you wanted to start talking about now and exploring now. So ambient AI listening, of course, this is what we have been working on for our last few meetings. So today we'll be kind of wrapping that discussion up so that Kristen and her team can get the information they need for that RFP for launching. Other areas of interest included telehealth and remote patient monitoring, and Marty is going to do a crosswalk of some of the activities that are happening within the Rural Health Transformation Program. So you'll see some of that remote patient monitoring work coming up through other programs as well. And then finally, group purchasing and shared resources. So that's also another area we'll be exploring. Some of the structural enablers that you all identified within our conversations were technical assistance and adoption support. So how to make sure that once these RFPs are launched and we have vendors and we have the solutions that have been identified, making sure that clinicians are able to use it and use it well. AI for operations and revenue cycle. This was another kind of key area that you'll see within the use case conversation later today, and then also robust vetting and governance framework. So thinking about how are we selecting the best vendor for Kansas's unique and specific needs. So that is an overview of our past few meetings. With that, I'll hand it over to Marty to do a overview of the crosswalk. So Marty, I'll have you come up here, I think.
Got it. That's kind of small. Good afternoon, and thank you everyone for making the effort to travel here. James, you've moved. We got to catch up. So, oh, you were so good. Thank you, Sheena. It's a very busy week in the world of rural health transformation. The Care Collaborative's report to KDHE on year one progress on the programs we are responsible for managing is due Friday. The preliminary year two budget for those programs is also due on Friday. KDHE will submit its report to CMS on August 31st, as well as the year two proposed budget will go on August 31st. To say things swirl in RHTP is an understatement because we are responding to CMS guidance. We are learning how these programs are operating. We're actually doing the thinking and planning that should have been done upfront as we're implementing. Our favorite saying, of course, is we're building it while we fly it. So we are loath to keep thinking about programs in particular swim lanes. We want to start thinking about holistically approaching the challenges for rural healthcare. Yesterday, we had an executive committee meeting with KDHE. That's a bi-weekly meeting with the KDHE folks, KDADS, administration, the state fiscal agent, BDO, the state's consultants, BCG, and the three of us from CCA. And had a discussion particularly focused on the funding pools. That's the dollars that are supporting the grant applications that have been made available. So far, they've done the regional partnership grants. They've done the transforming technology grants. Right now, they are evaluating the submissions under emerging technology. That's a grant program. The applications closed, August 10th? No, July 10, I'm sorry. There's going to be about $13.8 million that the KDHE has identified that will be funding projects. They received far more applications they could even begin to fund. And that is part of the challenge here, is trying a kind of a spit in the ocean approach to solving technology problems, is asking individual providers to submit applications and budgets. And are you really solving a systemic issue and meeting the challenge that way? So part of what we want to discuss today is the role this group can play in providing direction on those dollars that have been in that pool for year one. And are there specific use cases that you could provide leadership in, and then make solutions available on more of a statewide basis, similar to what we're doing with ambient listening AI. And that's where I want to catch you up. We go back to September, October as the state's application was being developed. This was a submission from multiple individuals, is using RHTP funds to purchase this technology for rural providers. And so the state's year one budget included the funds to purchase ambient AI for facilities that utilize Oracle. I was just saying to Scott, I'm writing you a $2 million check, which will fund the GPHA hospitals' use of that technology. We then will contract, I think there's 10 additional hospitals, Scott, that will be more direct contracting to provide them with Oracle, that resource as well. Next year's budget, the year 2 budget, includes the dollars for non-Oracle facilities to purchase a comparable product. And that's the work Kristen is doing right now, is developing the RFP that will go out to identify reliable vendors that match the EHRs that these facilities have, that have the ease of implementation that is in high demand by our rural providers. So that's use case number 1. It was decided for you, it was handed over to you, but that was because of what we heard during the application process. So the challenge for this group moving into year 2, year 3, year 4, year 5 is what is the next use case to solve for? And what's going to be the best early expenditure of funds, specifically in year 2 or year 3, that are going to provide the broadest assistance across the state. And so we'll talk more about how that budget's going to work as we go forward. But let's align that with other technology that's in the plan that's not directly tied to ETC at this point. But certainly, again, we want to get rid of the swim lanes and start thinking of this holistically. There is in the plan under Initiative 1 a set of consumer-facing technologies. This is in response to a very specific request from CMS in the Notice of Funding Opportunity for RHTP. And there are an assortment of projects ongoing here. That begins with Dr. Byerly down at KUMC Wichita. He's a psychiatrist that has been very active in the digital mental health space. His team is working on implementation of a product called Thrive, which is a computerized cognitive behavioral health therapy. And they have developed a very robust plan to deploy that in rural communities, leveraging community health workers and outreach to rural providers. And they are off to the races right now. They are finishing up the technology contracts. They are interviewing CHWs to fill in those positions. They've identified 3 hubs to operate from. So it's a early investment that's going very quickly. Also under this title is a program called LEAP that comes out of the KU Alzheimer's Disease Research Institute. It is a technology/intervention focused on brain health. And they are pushing out a product that's been used almost exclusively in urban areas to a very robust implementation in rural communities. And in fact, they've run their first pilot already. Their goal was to have 75 rural participants from 3 counties, and they ended up with 171 from 60 different counties. So there is certainly a hunger for that type of intervention. Next up is a consumer-facing fitness and nutrition technology. This is to be paired with other interventions that are part of the plan, such as the Food as Medicine program, the diabetes prevention program, but to provide a take home, shall we say, to the patients and residents that are participating in this program that can sort of reinforce behavioral changes around nutrition and exercise. Again, CCA is responsible for issuing the RFP for this project, which will go out probably now in August. There's a synchronous diabetes prevention program. The Medicare Diabetes Prevention Program, which originated with the YMCA now probably 12 to 15 years ago. Medicare reimburses for that service, but typically has been either a live intervention face-to-face, or it has been a real-time virtual interaction. Beginning this year, Medicare now reimburses for an asynchronous program so that the individual can self-pace so long as they have a live health coach and can provide ongoing weight measurements. But CCA is developing up a program to be available to be used by rural providers they can refer their patients to, that's tailored to the needs of rural communities. Dr. Bob Mosher, my colleague, has been doing the videos. I've watched them. I have a lot to go. I have a lot to learn, but he's done a beautiful job sort of tailoring them to Kansans. And then finally here, we are working with the Alzheimer's Association. Their program will begin this year, but it's targeted on a tool to assist families that have a diagnosis of dementia, Alzheimer's disease, to identify appropriate resources. Any questions on any of those? That's sort of our slate of consumer-facing technologies. Next up is the Anchor Hospital Advancement Program. Some of you are familiar with this. Chad, more than he ever wanted to be, probably. But this is identified 10 hospitals that typically serve as sort of the specialist resource throughout the state of Kansas. There's a very specific criteria that they use to identify these 10, but they have formed an organization. The CEOs from those 10 hospitals sit on the board. They've had several meetings. The energy in the room is amazing. It's like, I'm an old dog in the rural health space in Kansas. I was long exposed to the Friday night lights syndrome of you can't possibly get along with that hospital because we play on Friday night in football. But this team has really got a spirit of collaboration moving forward. But AHAP has been given specific piles of funds to build up resources for those anchors to support their surrounding hospitals and to develop up their specialist offerings in their communities. That includes a fund that's specifically targeted on AI and EHR optimization. It's about, Kristen, 9.8, 9975. Kristen is working with the AHAP team. Their use case is around revenue cycle. And so they are identifying an appropriate product that could be leveraged across the 10 hospitals. It's always a little bit off. Out of the 10 hospitals, there are some system affiliation, such as Manhattan with Via Christi, Garden City with Common Spirit, Great Bend with the health system. And so there's some navigation of that. But they are very committed to finding a product that works across their organizations. Anything to add there on that work, Kristen?
No, I'm not clear about these. And how we can start to think about not only then our system or facilities, but then how do you take that out to the right?
I know I'm jumping around on the slide, but I'm trying to do this in order of size. On the remote monitoring front, which is also a program that at this point is being implemented through the Anchor Hospital Advancement Program, this is a wearable technology from a company called BioIntelliSense that is used with inpatients to do continuous vitals monitoring. The data is transmitted to a centralized monitoring team that apply then algorithms to alert actual hospital staff for response. Some amazing examples of where this has been implemented and hospital systems identifying reductions in mortality, decreased length of stay, all of those positives we like to see. There's about 9.5 million in year one that's focused on implementation across the 10 anchors, plus we're thinking of 3 to 5 additional hospitals in year one, and then funding there in year 2 to expand that even further. It also includes a small pilot of using that technology for post-discharge. So that's that program. The Telehealth Navigator program is actually tied to an award that the health system received from the Patterson Family Foundation to build a virtual campus. This is hiring specialists, rheumatologists, pulmonologists, and neurologists in particular, that will be dedicated to providing telehealth services to rural communities. The tie here with the Telehealth Navigator is having an RN that's physically present at the clinic when the patient presents, so that there is clear connectivity with the specialists. That RN is then also doing all the follow-up care and scheduling services locally. That's part of the intended outcomes here, is to bring more of those supportive services into the local community rather than having the individual leave the community to see the specialist and then leave the community to receive those diagnostic and therapeutic services. We're starting with 3 telehealth navigators. We have hired 1 so far. 2 will be starting soon. And we have already started the neurology program down at Labette, and I think we're adding Emporia next week. So another one that's just off into the races. There are several other, we've noted on here, the Accountable Food as Medicine, Integrated Care for Dual Eligibles. These are programs with a broader implication, like Food as Medicine is that intervention in rural communities to focus on nutrition. But we are partnering with the team implementing Food as Medicine to provide remote patient monitoring for the individuals enrolled in Food as Medicine to monitor their progress, also to provide health coach support. Similarly, the integrated care for dual eligibles, that's really the expansion of the PACE program. But because there are so many communities, frontier communities, you could never get a PACE service available there. We're using a new ambient listening AI tool to be deployed in the home to support these patients, again, with the goal of keeping them in their home as opposed to institutional care. We'll be working on implementing that probably this fall. The data infrastructure program, which is part of the Initiative 5, which is harnessing data and technology. We are not directly involved in this, so I am not as familiar with it, but this is the category of building an all claims payer database, working on HIE connectivity, interoperability more generally, also providing some data, kind of the building of the data lake. And I'm using that term because Chris Harper understands it and I don't, but kind of having data available for use at time of service delivery. So there are several projects working in there. I lied. We actually do own one of these projects. The Diabetes Data Doc is a program between Children's Mercy and the health system's endocrinologists focused on pulling data from continuous glucose monitors as well as electronic health records to manage pediatric and adult diabetic populations. And there you are, right there at the bottom, which I think you're at the top, is the ETC. Where you were, the ETC idea, again, it's like, where did this come from? There, again, were proposals along these lines in September and October, but it really came down to figuring out how can we support rural providers as they're being inundated by vendors offering solutions and don't have the time or expertise to evaluate those opportunities and match them to use cases. And so could we have a bunch of experts come together in a room at the Kansas Health Institute and have Jason's Deli and then decide what are going to be the best solutions for them. That was the goal. Jody Schmidt always says, this is the good housekeeping seal of approval for technology for rural providers. That was the initial vision for this group. I think as we look forward, it's going to be so much more, particularly around what's the future in year 2 of that emerging technology grant pool, and how can this group be part of reinventing that into statewide use cases where you identify a range of technologies and then make funds available to providers to be able to use those technologies. Similar to what we're doing with the ambient listening AI, but finding other use cases where that can be applied. Now, the beauty of the ambient listening AI, surprise, is it's not that expensive. We actually over budgeted for ambient AI in year 1. Don't worry, we'll find somewhere else to spend it. But as we look to other use cases, we're going to be getting into higher costs. And so looking to this group to say, how do we define eligibility? And then how do we prioritize those organizations that would be, to which the technology would be available, at least dollars would be made available to purchase that technology. Of course, the good work you're doing, simply identifying the technology, is going to be highly valuable to organizations. They'll certainly have access to that work, but that next step up of actually having dollars available there. Okay, so that is a quick and dirty. Any questions on any of this? Any questions about RHTP generally? You all have got, Scott, I keep trying, but okay, awesome. Thanks, guys.
All right, thanks so much, Marty. Thank you. Just keep it up here. Great, thanks. Yeah, okay, so thank you so much. We thought it would be really helpful to, and thanks to Marty for putting that all together to see where you fit within the broader RHTP landscape, and where there might be opportunities to provide input into other areas that involve emerging technologies. And so the idea is that we're going to create a shared vision together. So And so we wanted to provide a little bit of context on the original vision for the group as it was conceptualized when the plan was being put together. So initially it was to help, or the committee would help identify technology solutions to improve outcomes and enhance efficiency for rural providers. Just make it easier, basically. And that's what we've kind of heard along the way in our first 3 meetings together. But now that we've done the charter, we know how we're going to work together. We want to move from how we're working together into that action. And so what we're going to do. And so we thought it would be great to have an opportunity for you all to come up with a collective vision, whether it's this or whether it's something else, to make sure that the activities in the work plan we're going to be developing later today make sense. So that's what we're going to do. All right, so we're going to create a shared vision together. It's bold, inspirational, and future focused, and it articulates what the ETC hopes to achieve and hopes to be in the future. So now I'm going to introduce you to your exercise, and for individuals online, you should have that available to you. So you'll open that document in your packets. It'll say visioning exercise or something like that. Okay. Great. All right. So this is what we're going to do. It's a right around exercise. And so we want you to imagine it's 2030. The ETC has become everything it set out to be. So we want you to describe what that looks like. What has changed, who has been impacted, and how is the world different because this committee existed? So what we're going to ask you to do is at your tables, and I think maybe you might need to move to another table. No, you're good. You're good. I'll just be a table of one. But we can join you. So you'll have this. So what we're going to do is ask you to take a minute and a half individually and answer this question and write that down. There are pens at your table for you to write. Just think through how you would answer that question individually. And then we will let you know when time is up. It doesn't have to be fully formed thoughts or anything like that. Whatever you think for the committee. And then at the end of the first minute, we're going to ask you to pass your paper to the left. And that individual will continue the thought of the first person. And then we're going to do it one more time. So 2 rounds of passing to the left. And then at the end, we'll pass it 2 back to the right, and you'll get your own paper back. For ease, go ahead and write your name at the top of the paper, like old school, or imagine you're in elementary school, and just to make sure we can keep track. All right, and so for those of you online, there's no passing involved. You'll just go ahead and write your thoughts about the vision. You can share them in the chat. Okay, yeah? You can, yes, absolutely. Okay, very good. All right. Okay. Wyatt is going to take it over from here. Go back. All right. Oh, there's only one. Okay. All right, so start writing. Find this table.
Yeah,
There you go.
Decipher.
Join right here.
Yes. So now you build upon the other person's thought, add to it. You can underline things, you can write things in the margins. Okay, 10 more seconds. I'm gonna have you pass, and this will be the last pass. All right, pins up, pass it. I know you're not gonna get everything down. Okay, finish up your thought and then pass it back to its original drafter. Okay, now it's time Okay. Come back to the full group. I know I'm cutting conversation short, but we wanna hear from each group. So if we wrap up. Okay. Time to share out as a table. So we're gonna start over here if everyone can give our attention to each table. All right, we ready? Our online folks are back. They're listening in. Online folks, we're going to come back to you at the end. We want to hear from each table. What were some key ideas for your vision for the ETC? We've got some note takers who are going to document some of the key ideas that you came up with. So someone from this table here who's ready to share some key thoughts. And use your mic. Scott, it sounds like you were voluntold, so
I was still right there.
give us your vision that you all talked about.
As a reminder, it doesn't have to be perfect. This is just, you know, throw the ideas out there. We'll fix it later.
So kind of approached it from the where are we at in 2030. This committee provide proven, trustworthy technology solutions to maintain Kansas' position as a leader of healthcare delivery and patient outcomes of technology solutions, and what do we say about data sharing for all providers and for the benefit of all Kansas patients.
Awesome. Thank you. And thanks for going first. So you all know what's coming. We're going to ask for your quick vision. Key things I heard in there. Proven, trustworthy solutions. Proven and trustworthy. We're going to come over here. You're now your table B. Who's going to volunteer to share a summary sentence vision? It's hard.
Okay, we had a lot of thoughts here, and this will be a little pulling out some words, but we like the idea of all patients are impacted positively. We like the thought that there can be foundational base level of tech that impacts your healthcare experience positively on the patient side and the provider/organization side, meaning there might be a tech starter pack that impacts patients, consumer-facing items, but also there could be tech starter pack on the provider or the org side. I'm going to pause so you can just write away. The analogy on the provider side would be food and water. Think of triangle, hierarchy of needs. What's the very base level? If we could get all organizations and provider facilities at the base level, that way we don't have some that are all the way at the top of the pyramid and you go and visit your provider elsewhere, other region, and they're still putting Post-its on the chart. And then when you move up from the foundation, of course, you're adding in this, getting to more of what would be our dream, our 2030 dream as you move up the triangle and you're adding in the cool factor when it comes to tech. Eventually the tech fades away where it's no longer the centerpiece. It's no longer the quote unquote cool thing that you're focused on in the room. The provider doesn't have to focus on it. Patient's not focused on it. It disappears. It's functioning and it's helping support you in the background of that healthcare experience. But it's not the third thing that's sitting in the room with the provider and the patient together. We like the analogy of when you had a really cool stereo and it took up half your living room and it was so awesome and you wanted to show it off, but now the speaker's just up somewhere in the corner and it just pipes throughout your house. No one sees it, but it's a good experience.
Okay. I'm sure there's more. We're gonna pick up these notes, but thank you for all of that and for the analogies. I heard some things emphasize the both supporting patients and providers, both ands, and then this idea of what is this foundational infrastructure and can we elevate that over time. Okay, Group C. Here, someone's already ready. Dick's gonna share
just
for
get
us.
ready, man. We got it. Okay, so first off, I think we want to think about this vision for patients, for the caregiving organization, the community, and the state. So we think the vision should touch all four of those. Patients get access to the vast majority of their care in the community and the region where they live. Organizations are thriving because they've embraced the technology and have efficiency and quality care delivery. Communities have stabilized and grown, and we have significantly closed the care gaps within that community. And the state gets recognized for having the most desirable rural communities, and there's a net migration into these communities because of the quality of life and of healthcare. I think we're done here.
The right person.
Thanks, Dick. So again, emphasizing that your work, and as you're thinking about the work of the ETC, you want to keep in mind not only that this works for providers, not only that it works for patients, but you've even extended it and think about the role that this can play in more broadly supporting a community and the state. Okay, our final in-person group, what did you all discuss for the vision for ETC and your work and how it will support rural health in Kansas?
So, I mean, we had a lot of different discussions on what the different things could be.
Get a little closer to the mic.
Sorry. We had a lot of discussions that are pretty much similar to A, B, and C, really. The one thing that we really kind of had was, everyone is 100% connected. And that means pharmacy data, including with hospital data, including with patient data. The caregivers have access to it. Basically, everybody's on the same page so that the patients, wherever they may be, and whatever specialists they see, whether they're on the north side of Kansas or left side, right side, wherever they're at, everybody has the same thing and that they're able to get access easier. And same thing with specialties and all of that. And somebody or an AI can automatically assume who's the sickest and try to get them into whatever situation they need.
Awesome. Thank you, group D, as we labeled you all, building on everything else, but then emphasizing that the data is available anywhere and everywhere, and we've included all these different entities and organizations. Sheena's ready, our online group. Terry, I see you on camera. Do you want to share some of your thoughts that you all had, or your own thoughts about vision for the ETC in this work?
Hi. Well, I'd like to hear from Robert, but Misha took some notes. I don't know if she's going to be able to share her notes, but I really like how Robert consolidated his with more of a focus on the objectives, where I was going with the committee itself, what the committee looks like and what the outcomes of the committee would be.
Well, go ahead and share those, and then we'll have Robert jump in. So think about the committee. What was your goals and vision?
So first off, there is a Kansas Health IT Advisory Council that exists. And so this feels like a little bit of an overlap with that council. And I know Emily and Leland are kind of running that, and Sarah's in that council as well. But so it's hard for me to do this because I feel like there's a little bit of an overlap here. But I would like to see a coordinated statewide vision for data interoperability and technology use. And I used Colorado as an example in our small group discussion where there's fewer legislative hurdles to battle in making some changes and doing some statewide efforts. But the committee would provide analysis, recommendations of systems for provider and provider organizations, and then all systems. I just added this one, all systems would have the patient, provider, and outcomes at the center of the vision.
Awesome. Thank you.
Robert.
Thanks for sharing. Yeah, Robert.
Yeah, so I'll kind of summarize because some of the stuff has obviously been mentioned a couple of times, but I think the biggest thing is just looking at still keeping it as emerging technologies and us trying to, we want to offer things that are proven and trusted, but we also want to be looking forward to if there's an opportunity to evaluate something with the group that we have to say, hey, this is something we can vet as experts, if you will, to bring something new. I think that's a big part of where we come together and make a difference. So just getting to that point where we're able to do that for providers and hospitals and everybody else. But also I think the other thing was balancing the solutions that we approve and recommend between what's good for patients, what's good for providers, and then also just operationally for the facilities, and then improving the health outcomes, like several people have said, and then also doing whatever we can to strengthen the rural facilities. I mean, making sure that the things we're doing, not just financially but operationally are benefiting those hospitals, because even if we have the technology, if we're not helping in some way to make them more stronger as a facility, like we're not going to get where we need to be if the hospital has to close because of some reason, one or another. Like that has to be a focus, I think, is a big part of it. And so if we do what we need to do, I think we'll get there, and the facilities that we're funding for these projects will be better overall. So
awesome. Thank you. And thanks, Misha, for helping facilitate that group. So we're gonna take all of this feedback and pull it together. But as we get ready to transition to our next things and my team gets ready, some things to lift up. We heard an idea of trying to balance benefit for multiple groups, not a in singular focus that this only works for patients, or it only works for providers, or it only works for the organization. And the other balance that I heard, we started with the idea of proven, trustworthy tech solutions, and then ended with, we want that, but we also want to create space to think about what's coming and innovation and new things. So keeping all of those, sort of balancing all of those aims, is part of how you all want to think about your work. And so keep that in your mind as we move forward into next part of our activity. We're going to revisit the ambient AI RFP discussion and wrap that up. And then we're going to go into use cases. I know we've been going a while. We're going to get through this and then we'll have a little break. So stay with us. Thanks for all the engagement and collaboration.
Where's Charlie and David? Yeah. Okay. So up till now, thank you to everyone for their participation in helping us really define what some of those requirements are. This group has done a fantastic job of outlining what are the operational, some of the technical, what are more of the cultural requirements that we have. But what we really need to continue to get into, and how do I advance this here? Sorry. Okay. What we really want to be able to get into is those facilities that we are going to be supporting. So who are those independent providers and facilities that really need to be able to weigh in on what is their current technology stack? What do we need to be looking at and understanding? We have some great starting points from the Oracle work that has already been done in the ambient listening. And what we're going to do is take a lot of those requirements and ensure that we have that we're on par with what is being offered to all of the Oracle ambient listening partners for all the rest of our partners. But understanding what are the current systems they're on, where are some of those gaps, and what are going to be those cultural hurdles that they're trying to work through are going to be that next level of information that we really need to get to. So if we want to, we can go ahead and skip ahead to the next one. Just to kind of give you guys an overview of where we are. As Marty touched on in the beginning, we were handed the ambient AI listening use case based on their initial information as they were putting together the plan. And so for us, through year one, we need to be able to get to having an RFP completed. We're getting closer. We're going to walk through timeline in a minute. Fielding that, coming back and having demos and making that vendor partner or vendor partners selection for our non-Oracle. This process will be exactly what we follow for future use cases as well. And this afternoon, we're going to talk about what are those next burning issues that you all are hearing from the facilities that you also help support. What are those greatest challenges that they really need to solve for? Right now, we're in the mapping out what the final requirements are, and we'll be going into building the final RFP, which will come back to this group for you all to bless and say, yes, we feel good about this. And then it will be fielded. And again, by the end of this fiscal year for CMS or for year one, so by October 30th, we will have gone through the demos and be making a final recommendation on who that partner or partners are. Here's kind of the timeline. The key piece we're at right now is getting those final requirements from the facilities that we are supporting, or that all of you are supporting, all of those rural health providers, and understanding where they are. So the assessment that we walked through at the last meeting, we have an online version of that as well that is significantly condensed to really get to what are the key technical, operational, or cultural challenges that they are facing. We understand that the majority of these facilities do not have the resources to be able to implement the technology, and there's going to need to be additional support. One of the topics we want to talk about later today is also, as we look at implementation partners and support, what we do in this upcoming year may look really different than what we do in years 3 through 5, as we identify some of the roles that the ETC really wants to take in delivering on this vision. So as we think about that, getting the feedback from those facilities and providers is going to be critically important. So we want to understand from all of you what is going to be the best way to do that and what role are you willing to help play in that. You can see here by end of August, we will have the RFP developed and approved by all of you. Then responses will be due mid-September. The week of October 19th, we will be planning for vendor demos. This does not necessarily align with the current ETC meeting. What the plan is that we will reserve a week. We will send out notices to everyone and ask you all to sign up and participate as you're able to. And then final recommendation that is approved by all of you will go to CCA and KDHE for the vendor or vendor partners that are selected. That's just kind of giving you guys an overview as we think about future state cases. They'll be handled the same way. We'll start with identifying what's the use case, the problem we're solving, defining the requirements, ensuring that we're getting the voice of the customer being both the consumer or the patient in some instances, as well as those providers and facilities, and then building out that RFP to help ensure that you all are giving that good housekeeping seal of approval, as Marty likes to say. If we want to go to the next one. Okay.
Okay, so we thought it might be helpful as we wrap up conversation. Oh, maybe to talk about just summarize what the conversations have been so far, and if there's any additional feedback that it would be helpful Kristen and her team to know as they're developing out the RFP. So we've so far discussed rurality. We've heard that the priority should be given to entities located in rural and frontier areas consistent with the intent of the funds. A suggested approach has been to start with the designated rural and frontier sites and expand a larger system serving rural populations using the Federal Office of Rural Health definition. Geographic distribution, we discussed that awards should be spread across regions rather than concentrated in a few areas. Distance to the nearest provider is suggested as a method for ensuring geographic spread, with the goal of reaching all geographic areas in the state, or at least trying to. Technical and organizational readiness was something else we discussed. Applicants should demonstrate clinician buy-in and a plan for staff training and change management. And making sure there's an easy lift for staff to implement. The organization should have an EHR installed. The type of facility, we decided not to limit the eligibility by facility type. So whether it's a hospital or a CCBHC or an FQHC. In terms of financial need, there also, the group was not wanted to keep the eligibility broad, and so not based on financial need, but just really based on whether they need the technology to serve Kansans. We did discuss multi-site grantees, but still under discussion. So about whether individual sites will apply as single controlling as individual sites, or if they have a single controlling entity like a broader health system, would the health system apply on behalf of everyone? And that would be implementing the technology. In addition, how mixed rural and non-rural systems would be handled. So I think right now we'll just open it up. If you have any thoughts on how multi-site grantees should work for this RFP, or if Kristen, you want to add any clarity on maybe how that's worked in the past or how that's been dealt with in the past, we can wrap this up and then move on.
Okay, sorry. Thank you. On the multi-site grantee, the one thing I would say is as you're thinking through that, we can also think about what does that implementation plan look like? So knowing that we will not likely be able to touch every single facility or provider group in year one or year two in this case, what would we want to look like from a rollout or an implementation standpoint? Is it that it should be rolled out at certain facilities first, and then you would bring on if you have multi-site? So I think the question is, how do they want to apply? But also, how would we want to think about implementing? Also understanding that there will need to be implementation support. So if it's a multi-site, should we be thinking about them differently from a support aspect?
The multi-site.
Yeah, there you go. Make sure you should.
I can't remember if we talked about this, but I was thinking two scenarios. So you have a rural provider who has contemporary EHR, and that EHR has a wonderful offering that's well integrated and implementable by the provider in partnership with the site. And the site's very comfortable with that. They're like, I don't need to go pick a third party. You know, my provider has it. I've looked at it. I've talked to other people, it works well. So I think you might have that scenario where they're not really looking for selection. They're looking for funding. The other is I have an EHR provider. I've looked at, either they don't have ambient, or I've looked at it. It's not well integrated. Nobody says nice things about it. I am very open to somebody coming in that can integrate with my EHR. Is that kind of an A/B? Because I think you're going to have a lot of people that say, you know, I have eClinicalWorks in my FQHC and it works okay. And they have, yeah, and I've either already implemented or I plan to. I could definitely use some assistance, but you know, it works, it's integrated. I think we're going to be okay. Versus people that are like, hey man, the stuff I got here, I could use your help and I could use your money.
So yes to how we thought through that, and will there be a plan? So that's the reason we keep saying vendor or vendors. Most likely it will be multiple partners. And so understanding what EMR and what systems are currently in place will be hugely beneficial for us to say, how do we need to segment what this looks like and how we try to address the solutioning? So as an example, for everyone that was on Oracle Cerner, there was a very easy solution to that. As we start to look at Meditech, it may be that Meditech, which today they don't have something sophisticated that's going to match, but is there something that can be close, or can they build it out? Or is there a singular partner that can layer into Meditech and make it work? So that's really trying to get that next level of information. The other piece on having something already implemented, I'm going to put Marty on the spot here because this question has come up multiple times. If it's already implemented or you're already in contracting, there is no support from a financial.
The exception would be I have a product today that I'm using. It's on the approved vendor list. Potentially eligible for future payments, but reimbursing money already spent off the table.
Like for what we're doing with Oracle.
Just a reminder, folks, please use the mic. People online can't hear you if you don't use the mic.
So what we're doing for Oracle is kind of the same concept though, right? Because they're going to reimburse for using the ambient.
That it's in a pilot product now, and it's getting ready to roll to a whole completely new contract that is like completely rewritten using tokenization as opposed to per note cost. It's a completely new contract.
So it's not going back, it's going forward.
Right. Everything moving forward.
So then for the other 10 Oracle sites, they will only get funded once they roll to the new contract. So question, just to be super clear on this, I mean, as we get to more expensive technologies, I mean, the beauty of ambient listening is that it's relatively inexpensive and there are the dollars already built into the plan. But as we get into more expensive solutions, we can't provide the technology to everyone. So there'll have to be some sort of very abbreviated application process. And so what we're looking at is how are you going to score these applications? What's that criteria going to be? Are there certain of these that are yes, no, like rurality? Yeah. But others of, is there a relative score that you could assign to it? Is that an accurate picture?
Yeah.
And something that's going to be wholly objective that folks would be able to look at and verify.
Alicia, do you have a question? Good. Okay, we can come back to you. So, all right. Any other thoughts?
Yeah, one thought I had is I think year one is pretty straightforward, but I think what would help is, our table talked about it, and maybe Dick, this is kind of where you're going is, it's not just ambient dictation, but as we look at rural providers, they're all going to be at a different stage gate, whether they have a mature EMR or just implemented it. So it'll be good to have a simple, I think like a checklist to say, that's what we're talking about is what's the base level provider technology at a foundational level that they can check the box and say, right, so that in the future, year 2, 3, 4, and 5, that, their needs may come in for an emerging technology at year 4, because, they can do a simple assessment and say, hey, year 1 and 2, we're really focused on foundational technology and security first. Then really think about, because one of the lessons learned we had is if you don't take care of your basic food and water needs or making sure my system is secure, jumping to an AI or emerging technology, don't even have time to think about that, right? And so I think just providing a very simple prescriptive way that all rural community providers can check the box on, so then they can kind of plan ahead and roadmap, whether it's resource needs or whether it's their year 2 needs. And so that's one thing that I think this group could maybe help develop together so that, we can be clear about what we're asking, not just from emerging technology, but our providers that we're recommending can easily understand where they fit in the need.
Okay, so Chris, thank you so much and could not agree more. And that was really part of the current state assessment that we started talking about at the last meeting. And while we have something right now, I think you even just brought in some additional pieces. The information that we want to try and understand isn't specific to ambient listening. It is understanding where they are. And I'm going to use, we have one of the AHAP hospitals who, as we've been talking about revenue cycle management, they said we implemented some automation in the prior auth space and we had to undo it all because we tried to time it at the same time as moving over to a new EMR, other systems. And so understanding where these facilities are, while we don't anticipate that they're going to be that much further along in the maturity level, it's understanding where they are so we can say, how do we best support you? And as we think about use cases or technology, and like you said, really that foundation, and I think you guys even brought that up into your vision, we're kind of talking about a dual operating model here. And part of it is how do we shore up that foundational technology infrastructure to ensure that they are able to engage with their patients and remove some of that highly manual burden that they have today. And then the secondary piece to that is, how are we future proofing, or how are we building for that infrastructure of the future where we're able to really talk about all of that data and systems interoperability. So we were going to ask you all, what do you think is the best way to get to? As you can see here, this is high level buckets. And then what we will do is update that assessment. And the intent is to keep it 5 to 10 minutes tops. We've had lots of conversations with these facilities on what are you feeling, what are some of your challenges, but we really need to get to what is that maturity level of systems, what systems are you on, what are your greatest challenges from a cultural or implementation standpoint. Knowing that all of you have touch points with all of those facilities, what do you believe is the easiest way to distribute and reach out to all of them to gather that information that serves as the baseline, not just for ambient listening, but as we then define what are those next priority use cases, to really be able to say, here's our baseline that we understand how we need to be able to identify partners to solve for it and best address those needs. I'm going to, how long it needs to be in the field, we might hold on that one. We know what that looks like for ambient listening, but as we get further out, we'll have more time to where we can plan for that with longer timeframes. But I think the very first question is, what do you all think is the best way to be able to reach out to all of those independent providers and facilities that ultimately will be the beneficiaries of the work that you're leading right now?
Sarah?
This might be a question that you parking lot, and it's really thinking about rural health transformation as a whole. So this information is vital not only for this, emerging technologies committee, but there's so much of rural health transformation that is based on technology and making sure that they're all ready. They have cybersecurity, all of those things. Are we doing a needs assessment in every single one of those pipelines, or is this going to carry over so that it's relevant and usable in some of the other areas? Like, I'm going to cross some of my lines because I do sit on the HIT advisory committee, but we're talking about health data utility and interoperability. And I think there's a component of that that talks about making cybersecurity resources and supports available to rural hospitals. And so how much of that is kind of overlaying? I'm just trying to make sure it's not repetitive. And that might be parking lotted for later. That's what I'm saying. It might not be a part of this conversation. It's just a thought I wanted to get out.
Great question. And same is going to be true for the commercial rate analysis, the ability to pull data out of their records. So the question I think I'd love to have this group grapple with and make a recommendation is, do we make completing the assessment a condition of being eligible for the funding? And if that's true, then we have to have really reliable lists. Now, thank goodness, Chad can cover us on the hospitals, but we're learning through the EBP program that it's more challenging to cover on the independent clinics, the FQHCs, the CCBHCs, and we have support of those organizations as well. But what are your thoughts on, if you want in the pool for this particular use case, this is, you've got to respond by X date on this?
And maybe even not only require it, but use the same nomenclature, because you don't want to, hit those rural providers by 15 different questions. And so the idea is that, create a single, type of a Q&A checklist, a survey that could be used. And then we use that as a framework to help address all of those different swim lanes. I think would be really valuable so that we're all rowing in the same direction.
Question on that is, completely agree. As we think about getting responses and getting them to complete too, there are a lot of swim lanes. Some of this is, what can we address today? Some of it is, what should we be thinking about by year 3 or 4, right? Is there any benefit to sequencing to where it is requirement for being eligible for the funding, but if we can get all of the right stakeholders, I know we've talked about this with evidence-based and some of the different groups, come together with what is that list of questions that we need to really be able to start even planning for the next year, and then know that we have the opportunity to come back. The concern of putting too much in up front means we won't get really thorough responses or people are just trying to get through it to be. So what do we need to know? And then how can we sequence that so it becomes kind of like an ongoing conversation, especially as needs get further defined and what those questions are can be refined as well.
Are you thinking like a phased in approach? Like this is the minimum necessary information we need for phase 1. And then phase 2 is now we're building on that.
Yes.
Just clarify something you said earlier. I want to make sure I heard it right. When you and Chris were talking, the current assessment regarding food, water, foundational, current, did you say that current state assessment has already been done, which is different from the ambient listening assessment that the QR code was up there for?
So we started a current state assessment with this group in the previous meeting.
Okay.
But we had attached a link that went into much more. And the question we have is, so we recently have done something very similar with AHAP. And it was understanding kind of what are the systems, what's the maturity, what are you using, all of the same types of questions. It's really that baseline. That is, what do you have in place? And if you have an EMR, is it meeting your needs? What key functionality that we know are some of those top use cases do you have turned on? Where have you tried implementing AI if you have, and why was it not successful, right? So getting to, as simplistically as possible, the food and water piece, and then what would they need, right? Where is their level of being able to self-sustain, need it versus needing support sustaining?
So the current state that has been done is with the anchor hospitals. We need the broad, widespread current state.
Yes.
And then the current state for each of the different new categories we're looking at.
Right. Or we can go deeper on current categories or use cases as we get to those. This is really, how do we start to look at for the state of Kansas? Here's kind of that baseline that we have for all of the constituents that will be applying for funds, regardless of what the swim lane is. Is that a fair way to put it? Okay.
And I guess thinking about implementation and the timeline for this particular RFP, there may be some limitations. So maybe a phased approach is what you were thinking.
Yes.
Yeah. Okay. Great. Okay. I need to move us along if we want to get to use cases.
Okay.
All right. Any other thoughts before we transition to use cases around the needs assessment? If you wouldn't mind, you have some notes or, you want to jot down any ideas on who should take it. And we're thinking we want a broader group to take it. How it should be sent out. So I would just charge all of you as representatives for the committee to think about how might I play a role in disseminating the needs assessment for providers and clinics to take the survey. And then thinking about how you will use the information to inform that RFP. And we're hearing that it should be a requirement for eligibility for funding. And so we, at our next meeting or in between, can also reach out and get that feedback from you.
And I think that with a sense of urgency for ambient listening,
right,
as well, as you think about it, what is the best way? And Chad, I know you probably have some ideas too for being able to really reach out and connect with a lot of the different groups that Marty just kind of walked through.
A hospital association perspective, obviously we do a lot of surveys and we have a lot of access to our members. So that's something we can easily do. And I would anticipate, the community mental health centers can do the same thing. The FQHCs can do the same thing. It's really just kind of looking at what that baseline survey is. And, the longer you make it, obviously it's going to be more challenging for people to complete it. But the response rates, I think you can get pretty decent responses as long as it's a meaningful survey and we kind of articulate how it's going to be used and get their buy-in. So I think there's some opportunities for that.
And I want to add, just like the evidence-based program that's happening right now, you have to do the things or you're not getting the money. Right. I think that's what we need to do here, or you're not. Yeah. And to that end, we have a decent list of the independent practices, so we can cover those as well. But there's also the advantage of being able to size the RFP because we'll have an idea of how many organizations are actually on board. We don't have that right now. we have a guesstimate, but not anything accurate.
And so if you want to take a look at the tool as it is now, and if you also have any feedback on the tool itself, you can use that QR code and we'll also send it out after the meeting. So any thoughts or feedback on that would be helpful too.
And so, Sarah, I'm going to address you specifically, but anyone else, if there are questions that you say, you know what, for a different initiative, it would be fantastic to have this set of questions that goes in there. Happy to be able to modify that however needed. Again, goal should be to keep it under a total of 5 to 10 minutes for completion. So we can modify however needed to reach these entities.
I have an idea that rather than doing it here, I'll follow that.
Perfect. Great. Awesome. Okay. All right, we think we've covered a lot already. We had anticipated wanting to give you a 15-minute break, but that's no longer possible. So we'll just give you 5 minutes, just get up, stretch, use the restroom, and check in, and we'll come back at 1:50, about 1:50. Okay.
Not extended.
All right, can we, I just meant with that.
What's the name of the woman online?
All right, if you want to wrap up your conversations and find your seat, we're going to go ahead and get started. About 1 minute. All right. Okay, so we're gonna continue our conversation or wrap up about the needs assessment. So I'm gonna have Marty. Is that the plan? Okay, grab Mike, and you'll be, or I'll get you one.
Scott, he's a great assistant.
Perfect. We're all facilitators today.
So this is react to an idea about moving this forward. And this, trust me, this is RHTP. We throw things on the table, we look at it, we modify it, we move with it. The speed of RHTP is crazy. But if to launch this, and if we are going to use this idea, complete the assessment as a precondition of receiving funding under this particular use case, right? So an expression of interest. So we need to get that out in the provider world. Do we say, let's pick a date for a webinar, rely on Chad for KHA, Terry and Robert for FQs, Michelle for the CCBHCs, we've got the independents, get this message out there, do a brief webinar introducing ETC, show them our new shiny vision statement, right? That kind of stuff. But then talk about this assessment, future plans, talk about the assessment, get the assessment tool out there. If we've got useful tools, we can finagle Chris into talking about how to use those tools. If anyone else has an idea of participating, am I going in the right direction? Ideas, feed that. Things we're missing. Bueller. Webinar, yay.
Yay.
Thumbs up, webinar?
Thumbs up, webinar.
Okay.
More information.
And we'll record it, of course, and put it out there. Okay. Anyone down? Yes. Oh, we never do anything we don't record that they can watch again. I go home and watch them.
And just one really quick note, I think it's come up a couple of times. All of this information that we are gathering in the current state will be available for everyone. So it will become kind of the baseline for all of the different programs operating under RHTP to provide kind of that baseline current assessment for technology and where they are as an individual organization. Great.
Thanks, guys.
That was the most productive in-person meeting.
Great. All right. Well, now that we wrap that up, I think next steps are to talk about use cases. So the idea is that for this particular section of the meeting, we're going to take facility and provider input that's been received to confirm the focus areas for ETC in years 2 and potentially beyond, and prioritize those use cases for year 3. And then Marty, and we're going to talk about a potential opportunity that we could start a little bit earlier in year 2 to work on use cases that she mentioned before. And then that will lead to those RFP requirements process that Kristen just went through, that we're going through with the ambient AI listening RFP right now. All right, so how have we got here? We had in meeting 1, compassed exercise discussion that Shelby went over early in the meeting and survey responses. So we collected those challenges and potential solutions. There's been some additional field conversations based on subject matter expertise with Scott and others, Chris, who's implemented this technology before, in addition to some rural providers. And 2 focus areas emerged. One was on revenue cycle management and the other on workforce optimization. So today's goal is to confirm those focus areas and select 2 use cases within them, or at least prioritize them. So I'm going to turn it over to Kristen to provide more detail.
All right. So as we say, and I want to come back to really quickly, there was a lot of conversation about interoperability. We are not taking that off the table. That is our year 5 vision, 100% of what does it look like to be fully sustainable as RHTP funding goes away? And what do we really want the future state of rural healthcare? The questions that we've had in the conversations with many of you and also many other rural providers around Kansas are, what are those foundational items that you really need to focus on right now or shore up for a sustainability, a financial sustainability for your facility today to ensure that you are here in 3 to 5 years, or that those providers that you are supporting have that financial sustainability. And the two areas that keep coming up are really around the revenue cycle management, and very specifically getting into the prior authorization and some of the challenges, denials, which as you get into that, there's many different pieces as you look at that revenue cycle management, right? So some people are going to say it starts at registration and capturing the right information or getting to that eligibility, all the way downstream to being able to challenge on denials and then collection. So we have revenue cycle management has been one of the key areas that comes up. And then the other is augmenting the clinical workflow. And so I want to give one caveat there. Scott, you've mentioned it. Chris, you mentioned it earlier. And I believe someone else, okay, I'm thinking maybe it came from Labette, that our facilities don't necessarily have, they aren't all in a spot of maturity to be able to implement AI today, that they are still working on manual flow sheets and someone is then entering them back into their EMR. So as we think through that for the secondary area of the workforce optimization, we're going to touch on some of the different use cases that have come up. Again, this current state assessment that we need to get to will help us understand where to start in that. So even if we were to say, we think this is a fantastic use case, once we dig in and understand really where those facilities are today, we may say we need to start that process earlier on, but this is to give us directional areas that you all say, these are the most critical areas that we want to be focusing on. So I'm going to pause and say, do revenue cycle management and workforce optimization or clinical workflow support, do those come to mind as the top 2 areas for all of you as well, and what you're hearing from those individuals that you're supporting? Or is there something that's not on here that we need to add? I'm seeing some thumbs up. Thumbs up. Anything that's, is there something that isn't in one of those 2 that you guys say, you know what, you're missing it, it is a burning issue for our communities? All right. Well, we assume this is going to be kind of easy because it's been,
trying to get the mic on. Just in terms of revenue cycle management, are we talking about the front end of the revenue cycle as well? Because I think that would be another area in terms of patient reg and scheduling things.
Well, and so I think, yes, so that's, it could start at registration and scheduling, or maybe it's eligibility, or maybe it's just automation and the prior auth. And so those each come in as different use cases. And I was explaining to Marty earlier, I think there's a total of 10 kind of key stops along that journey, that some of them you can solve for in and of themselves, and others you need to actually have that front end piece first. And so, yes, as we identify what are those biggest challenges, we can determine where do we start on that.
Perfect. Yep.
All right. So we're going to go in and have you all then help us further prioritize the use cases that sit within those 2 key focus areas. And as you're doing it, coming back to the lens of the financial impact, the workforce, operational readiness, how quickly can we start to recognize value for these providers, alignment with the vision that you all came up with, right? And the financial sustainability. And as we think as a group that is going to be that trusted advisor, the financial sustainability is going to be a piece that we keep coming back to. Knowing that within 5 years, this funding will no longer be present, that anything that we implement now, that we need to ensure that there is a net positive ROI before that 5 years is up for any facility that we're implementing it at. And so as we think through that, those 2 areas both represent an opportunity to say very clear realization of financial impact and reduction in workforce hours. As we get to some of the future state and we talk about shared infrastructure, that financial sustainability becomes not harder, but a more complicated value statement. And so as we think through some of these very near term, the financial sustainability, and I'm just putting that, will be something that we'll continue to say that has to be part of our RFPs and our use case definition to ensure that we're able to demonstrate net positive revenue for facilities that implement this before that 5 years is up. Is that good with everyone? All right, let's jump in.
All right, let's do it. Okay, so if you want to talk through some of the things that we've categorized under each area, then we can go into our prioritization.
So use cases, and this is going to come back to your question you said, Erin. Do we want to add registration and scheduling on at the front end of this? We can. Right now, what we've identified as those core use case areas are starting with eligibility verification. For many of you, that is, you already understand that it is when you go in to place that order to know what that patient is actually eligible based on their plan that they are currently covered by. Being able to put some guidance into those workflows is kind of where we look at that from an eligibility verification. Prior authorization, starting with identifying whether or not a prior auth is needed and then automating that submission. So that is pulling in the documentation, submitting through the payer, and then status checking and identifying the denials piece of it. Denial prediction and management comes more into that back end, being able to identify what are the appropriate codes that need to be going on there. How do we flag when something has a likelihood of being denied, and then reworking that or taking that manual process out. What we hear from all of these facilities is the number one time spent from their very small rev cycle teams is on fighting denials. So how do we pull in the appropriate coding and the documentation needed to fight those denials on their behalf? And then billing and collection automations. And this actually comes front end and back end. So again, Erin, as we talk through this, it gets to that estimation and then the billing and the collecting. So as we think about where to start, it comes into, and think about it from perspective of either your facilities or what you hear from the facilities that you're representing or providers. Where is the greatest challenge and where would they see the fastest path to having value realized? And then we can focus on future. And if you put these all the same, we can say that's great, and let's figure out how we solve for all of them. And then can we go to focus area 2? Yep.
So even before, like on number 1, like even the patient comes in, where if we're living in a dream world, say, hey, they were just in the ER. I mean, give us that information, or hey, they just went somewhere and had these diagnoses. I mean, if that can be something from the get-go, I think that would be helpful as well.
Yes. Okay, so as we try to solve, and I'm going to make this use case more complicated as we talk about that, because we then have all of those transfers of care. So even as we start talking about rev cycle, some of our facilities say 50% of them, 50% of my procedures are being referred from within our physicians or our facility, and 50% are coming from outside, and I have zero visibility to that prior auth process. And so all of those pieces on that transition, it will be capturing how do we best solve for that lack of information. And if you all are coming up with what the standard needs to be, it doesn't mean that we have to work the system the way it works today. How do you completely want to rethink what this looks like, and who should own processing that authorization? Should it start with where the procedure is going to happen and starting to create what does that new workflow look like? Yes.
This is a little bit further upstream, and I don't know that you would consider it part of your rev cycle, but what about your payer contract management? Would evaluation of those contracts and whether they need to be renegotiated be part of the process, or?
So I think it will be a separate process and can definitely be an add-on use case. Just like estimation and billing, if you have the rest of this piece going, the estimation and billing are going to become much less of an issue. However, as you get into your eligibility and your denial management piece of it, it's going to very quickly highlight where you have an opportunity to renegotiate those contracts. And so this was really saying, how do we focus on the areas today that are bringing the greatest burden every single one of them is going to highlight probably another 10 use cases that we can then come back and say, how do we want to tackle those and how will we prioritize those? And just so everyone feels good, you're going to have an opportunity to add in something else that you think isn't covered up here if there's something really missing. Workforce optimization. The biggest challenges we've heard are today when I go into my EMR, there is a ton of information and I don't know how to get to it. So how do we start to add in additional information that can be standardized, that can work into the workflow to take some of that guessing game out? Knowing that every system or facility is in a different place, this was meant to say, how do we take the information that can be, I don't want to say static, but can be standardized and served up within workflows?
Quick comment, sorry.
Sure.
Standardized or summarized, that you have all the different inputs from 18 different EMRs, and it goes into an agent that summarizes that care from the past 5 years for that patient, and it's right there in front of the specialist or the primary care who's just seeing that patient for the first time.
100%. Perfect. So here are just 4 of the top areas that have come up repeatedly. Again, they are summarized to say each individual facility has had some very different or very unique things that they would like to address as we think about this collectively and how to best provide direction and that gold housekeeping seal of approval. It was saying, how do we look at those that we can do from more of a standard or a summarization aspect? Okay, if we want to go to the next one. So we have an exercise, and I'm going to let Sheena walk us through how the exercise works. But as you go in to vote, if there is something that is outstanding that wasn't up there that you all really want to make sure is being captured, let us know that. And we can certainly, okay. All right.
The way this will work is if you can scan that QR code, it's going to show you a list of all those options that were just discussed. You have 100 points to distribute however you would like across those 8 areas. If you want to spread them equally because you think everything is equally important, then do that. If you think you want to focus on 2 things, then do that. So you've got 10 points or 100 points to use across those areas. And then we're going to give you time to respond, and then we will show the results. We won't show them until folks have responded so that your opinions aren't biased by what you see other folks say.
Surprise, we were worried the technology wouldn't work, and we'll fix it.
Right survey. Yeah, we have a 3-question survey. I understand the practice, right?
Oh, there. One moment. That's the second question.
Yeah.
Can you reset it?
Sure. Yep. Sorry about that. If you refresh, it should update. Got advanced on us. Sorry about that. We wanted a way where everyone could anonymously share their feedback, so thanks for dealing with us. I'm walking around, so if you still have issues, let me know. We can figure it out.
Is it coming up now for you? Okay, great. Perfect. Just give me, no?
I'm still getting the other.
Oh. Anybody else need help, raise your hand. Wyatt will help you, not me. Beautiful.
So and it's a long list, so scroll that if you don't see one that was mentioned. If you just put your phone down when you're done, that'll give us an indication that you're not working on it anymore. Okay, looks like folks are finishing. Got responses coming in. Maybe anyone still finishing? Couple people still finishing?
All right, so out the 2 use cases, the top 2, it looks like denial prediction and management and prior authorization automation received the most points that were allocated. How is that resonating with all of you?
Well, they kind of go together.
Mike, you're good. I know.
I think in many respects they go together.
Okay.
I mean, if you do really good prior auth, you
Yeah.
reduce denials. So I mean,
In general.
I'm not saying they're, opposite sides of the same coin, but they're really part of a good, strong revenue cycle process.
That makes sense. Okay.
So I would agree. And I think if we look at that top piece, and I think that comes into, there's going to be limited dollars. And so as we identify the different partners today, there is not a singular vendor that can address that entirety of those challenges. And so when I say it's really broken down into 10 points, I think the most anyone has is 6 of them right now. And so as we go in to say, how do we start to solve for this? 100%, they are all tied together. And so we can start to say, for denials, prediction, and management, you are going to have to start upstream. But then we know that we need automation in that piece of it too. And so we can start to say, what does it look like for solving? But to me, looking at this, it really clearly says revenue cycles where we want to start and map out that process. But I would agree with you 100%.
Revenue cycle jumps to the top.
Revenue cycle jumps to top. Yep.
All right. So 2 quick caveats.
Chris wants to.
Oh, go ahead, Chris.
No, I think so. One thing that I know, I think it's embedded in number the provider efficiency, but one thing that was valuable to us is just a simple thing like in-basket management. So, because I think for 2 things, revenue cycle and providing efficiency for your provider just seems to be the ones that really pays dividend if you get those things going. So anything that we can enhance and free up our provider time, like managing in-basket, to me that was a huge win for us.
What category would that fall under?
That's what I was trying to figure out, is where does that
And we
fit?
can add it later. We have an opportunity. This will work out. Okay. Any other thoughts? Oh, yeah.
Sorry, I just wanted to add one thing. I mean, all of these are extremely important. However, one of the main things that we all have to consider is the people that are entering this stuff in the first place are probably our least paid employees. And they're in charge of making sure that the name is correct. If the name is off by 1 letter, all of that goes out the window. I mean, we have to have some system to where the humans that are in control of putting the stuff in actually shows us how to get the prior auth and everything else. So just
Human in the
keep
loop.
it. Well, I mean, it's garbage in, garbage out. If we got the wrong things in, we're never going to get the right things out of it.
All right. Okay.
Sorry, one comment on that. From our Great Plains Health Alliance, we do an annual meeting and we have all 30 of our hospitals that came. We actually did like an hour-and-a-half presentation on that thing, and maybe workforce education or some type of way to get your entry-level type roles educated on saying, this is how important you are to the entire rev cycle. You guys impact everything on what we do every day. So it's important that you do your job well. Exactly. So do you script that education and how do you reinforce that with them as they're entering that information, or as continual reminders of it? Is there some type of workforce education available?
And I think that registration and onboarding of a new patient is what I'm really hearing. And do we add that in and say, what does that start to look like and what potential solutions exist today?
Is there a component of that is covered under the eligibility automation? Because that's obviously going to identify a mismatch prior to a service being rendered or claim being sent.
Yeah.
So the use case that may fall under there is a AI assisted coding, so that it really makes it easier on the provider and the your revenue cycle team, so that and you preload a lot of those data so that both clinician and your revenue cycle team member can leverage both. So there's an AI assisted coding component that could be also part of that.
Okay, so I'm going to give one quick caveat. Based on our webinar, the timeline that we had up there for the current ambient AI listening, our end date will still be the same, but some of those dates in the middle are going to be pushed a little bit based on when we're able to get that webinar scheduled. So I don't want anyone to be like, here's our hard deadline. We will get that updated for everyone.
Yeah, very good. Okay, so I think for today's purposes, thank you so much. This was a great discussion, and we're going to have opportunities to dig into this in a little bit. So I'm going to move us along. So we had to prioritize the 2 use cases for next year. It's looking like it's going to live in the revenue cycle. Now thinking about, we've talked about use cases. We've talked about the ambient AI RFP. Now we're going to work into work plan development. So as a part of this committee's role, and as we discussed before, it's in our charter, we owe CMS and the state a work plan for the committee's work in year 2. So that's what we're going to spend the rest of the time together developing today. So we're shifting the focus from the charter to action. We're going to translate the structure of the committee into concrete initiatives for rural health in Kansas. So what we've been discussing thus far is going to roll into the work plan. And then we're going to build a shared roadmap that aligns the committee around common priorities for the year ahead and maybe beyond. There's a balance between let's get something to what we need to do for year 2, but we have to think ahead a little bit. So our objectives are, we're reviewing the potential topics for year 2 ETC work plan. We're going to identify the focus areas with the most potential to be transformative for rural health in Kansas. And we're going to develop activities, success metrics, and timelines for each focus area. They don't have to be exact. It's just that we're going to do a brainstorming session. But you've prioritized those 2 use cases, so those will roll into a couple of topics we'll be discussing. We're going to have Marty talk about potential opportunity for the committee, or I can talk about it with your additional support to inform future activities in year 2. Given the budget that's available. And then you'll have an opportunity to identify other ideas that we might want to discuss today. We only have room for 4 groups, but that doesn't mean we can't continue these conversations, but we'll have 4 different table discussions. Okay. So today we've talked about the vision, and we're going to be talking about priority focus areas. I just wanted to let you know, KHI is supporting the development of this document. It will also include the purpose and context, acknowledgements, the work plan development process that we're going through today, and our guiding principles that we talked through during the charter development. So today we're just going to focus on the bottom 2 areas, and we'll support drafting the rest. Okay. This is like... So within the focus areas, we'll discuss key activities, deliverables, timeline measures, the role of ETC and partners, how they will play, how you'll conduct outreach and engagement activities, the resources that might be required for each of the focus areas, and what sustainability might look like. All right. So We have already have some established ETC activities. As Marty mentioned before, given the timeline, the rapid timeline in year one, there were some decisions that had to be made so that you could start providing input right away. So that's the ambient AI listening. We've spent a lot of our time. Year one looks like RFP development. Year two is implementation. Year three is implementation. Then you have the 2 use cases that you just selected. Thank you to my fairies for filling that in. Denial prediction and management and a prior authorization. So we'll have 2 groups that are going to be discussing each of those use cases. Additional activities, that's where we have some room for you as a committee to decide what else you might want to focus on in year 2. I did want to provide a little bit of guardrails. So if we're looking like we're going to have about 10 meetings, 10 monthly meetings in year 2, that's thinking about doing the top 3, so implementation of AI and the 2 use case RFP. There might, realistically, thinking about 1 additional activity the group wants to focus on in year 2. The other activities that you might think would be prioritized, that could be we could start talking about those, and that might be a year 3 thing. So really want you to think about next year, if you could do 1 thing, what would that 1 thing be? Sorry, the clicker is a little bit opposite of what my intuition tells me. So before we get into that, there is the idea and the issue of the KDHE RHTP Emerging Technology Grant Program. That is in place for year 1. And so do you want to talk through what that looked like in year 1 and the potential opportunity the committee has to weigh in for year 2?
KDHE is still in the process of processing the applications for the ET grant program. But the high level information we're able to share at this point, and CCA is always blocked out. We are not engaged in any way, shape, or form in evaluating or making these awards. So this is just info we've received from KDHE. But there were 72 applications received for what will be about a $13.5 million pool of funds. What the state has done is programs have resized dollars that and dollars are moved around. They've sort of dumped the extra money in emerging tech. So that's why it's gone up to 13.5. This is a very broad summary of the types of requests that were made in the applications. There are several, as you would expect, that kind of cross several of these lines, but it should give you some concern, some feeling of what the interest levels were among applicants. We had I think I mentioned this previously, we had our executive committee meeting yesterday, right after KDHE had spent some time with its consultants scoring applications. And sort of the reaction was, we're spitting in the ocean. And is there a better way we could be spending this money? Which was a great time for us to say, well, by the way, we have this idea that you've got this emerging technology committee. They are leading and supporting the implementation of the ambient AI solution, rather than year after year having this funding pool that takes an enormous amount of effort on the part of KDHE and its consultants to score those applications. And it creates a level of frustration among applicants. 72 applications, maybe 10 to 12 of those are going to be funded. Maybe higher, but it's going to be in that area. So our question to the executive committee as they're working on the year 2 budget is, does it make sense to take some or all of that pool? And right now, the working line item in the year 2 budget for the grant pool is $12.4 million. That's most likely going to have to come down because of needs in other programs, but I think it is safe to say it will be at 10 million. But rather than treating that as an emerging technology grant pool, should that instead become your kitty? And that ETC leads initiatives and very purposefully saying, now we're going to do revenue cycle, or now we're going to do X, and we'll develop the parameters. We will We will release the opportunities. We will set the priorities to determine how those are going to be scored. And at the end of the day, yeah, CCA still ends up being the contracting party, but we're doing it at your direction. It's, it goes both ways. And certainly there are loud complaints that the RHTP process has not necessarily been democratic. But is this a way we can provide a statewide direction in the expenditure of these monies? Secretary Stanek was very open to it. In fact, she was probably the first to go, why do you only want part of the fund? Why don't you take all of it for us? Because I mean, these grant programs they are, again, democratic, but they still lead to a lot of questions and folks concerned that they don't have the resources to submit the applications. But granted, you're stealing decision-making away from them and telling them, here's the solutions available with these dollars. So, and it's a big role, right? I mean, you're putting your name on the line if you're on this committee and you've got providers that don't like what you've selected and vendors that aren't going to like what you've selected. I'll be honest about that. But would love your reaction, love your recommendations to KDHE. Sort of your level of interest. If you had 100 points, how many would you hand over to this approach? Because certainly taking this job on kind of with a average level of enthusiasm probably isn't going to get us through 5 years. But if this is a role you all feel comfortable playing with your certainly having your colleagues inform this as well, it's there for the taking, shall we say?
Okay.
How often do you get asked, would you like $10 million?
Yes. Any thoughts or comments about that approach from thinking about hearing from providers or hearing from others in the room that really kind of have an ear on the ground? Oh, Terry.
I think taking the approach that this committee would be involved in determining how the funding will be spent. I think a lot of us would be taken out of, we would have to leave the committee or leave those discussions because it would also maybe conflict with what we potentially would be asking for as an organization or as a group. So I think that needs to be given serious consideration if you're planning to have that 10 million allocated by this committee. I just see potential conflict of interest.
I've got another comment to make on this with the idea of trying to meet these hospitals where they're at and their needs. If we had overall themes that this committee would put together that we would propose as solutions, we would have to do so very thoughtfully on the offerings on how we would meet those hospitals where they're at with those needs. So that's my.
Okay. Any other thoughts?
Can you go back to the slide that where the 72 proposals, what areas they asked for? No, it was the one that you just reviewed there it is. Okay. So this was open-ended, right? They could have asked for could be prior authorization. It could have been, does it catch anybody else that what they actually submitted round one was not what we just talked about as revenue cycle being?
One thing I'd note, Dick, is diagnostic and imaging was folks that wanted CT machines.
Okay, all right, well, that helps. And I'm sure it better than AI documentation had to be better coding and things like that. But I would have thought, given what we just talked about, that there would have been explicit things around revenue cycle, because I think it's at the center of what ails rural healthcare is they're not getting paid fairly. And it costs too much to collect. And I thought it would just like jump off the page.
I wonder if the timeline from when that was released to the time it was due might have impacted because you needed to be so strategic about what you had enough information about and what you were able to get in that application as quickly as possible to turn it around. I wonder if that played some part of it. Yeah.
And you know, from my perspective, you know, from what we've heard from some of the hospitals is that I think what we saw in year one is going to be much different than what we see in year two request, because I think year one is just kind of just the basic items and the themes are kind of similar, whether we were talking about the capital improvement or the regional partnership, and then they were just trying to fit items into the same bucket. I think as we get into year two and we get more opportunity for entities, whether it's clinics or physician practices or hospitals, whatever the case may be, I think you'll start seeing a more strategic kind of application that they will be going through. I think, you know, from my standpoint, you know, I see a little bit of both in terms of whether or not we want individual applications or a use case model. I think, you know, the point's well taken as the individual applications, even though yes, only 1/7 of the applicants may be completed or awarded. You know, I think there is some value to be able to at least have individual entities have the ability to kind of promote their idea or their needs, and allows, you know, while it may not be a majority of the time, but portion of the time that they can have, you know, ideas that might be funded. So yeah, I know it's more work, but you know, I do think sometimes having individual applications, whether it's for, you know, original partnership grants or emerging technologies, sometimes might be beneficial for some providers.
If that's the, oh, go ahead.
One other thing, Dick, I had forgotten this, but as Chad was talking, I remembered there was something in the application that a statement about making sure patient care was at the center of the application and that the tools in the proposal were not too focused on the back office. And I wonder if that impacted people saying, if they considered rev cycle to be too back office to be selected, they might have gone and switched up their application for that. But I comment to Mari, I do think the other thing is, so there's 72 that came in, but I think we have to consider that we're looking at the 72 that had the resources in that time frame to get an application in. That probably also impacts what we see in the results there. But I like your idea, whether it's this committee or some other process, I like the idea of being able to be more widespread and democratic with where it goes versus potentially the money going to the organization that had the resources to get it in. And then the ones that didn't have resources might have needed it, but are going to be left out.
The other thing that we could discuss, so if there's a combination, some sort of combination, maybe some funding could go to use cases that are selected by the committee and others are still kind of available for grant funding. What direction could this committee provide in order to kind of share feedback or share topic areas or types of funding that would be included in the grant pool in year two? Is there a role for the committee to play in that?
The word that keeps coming to mind is this transformational impact. So I think because people are living and trying to solve day-to-day problems, having an overarching view that's like, yeah, we got that. But if you want to change fundamentally and sustain the change, these are the 5 areas of technology that we would like to invest in with you throughout the state. So, and here's why. So I like the idea, Marty. I think it's really wise to think about stage setting here to say all problems are important, but we're not going to fund all the problems. There are things that you're going to do out of operational, needs, but for the state and the things that we see across the regional, needs, these are the 5 things over time that we want to make sure are in every health system, in every community, because when they get done, we see a transformational and sustainable effect. So I think there is an important role for the group to play, whether we're sitting around a table reviewing RFPs or scoring them. I don't think that's a good role for this group.
Yeah, thank you. Sorry, go ahead.
Even standardization, even standardizing
on certain platforms. I think you get some benefit from that because I think all of us agree being on different EHRs makes some things more difficult. So.
Great. And Terry, we noted your comment in the chat. She likes the approach of letting the committee set the categories of funding. Okay.
Yeah, I was thinking maybe we could, doesn't have to be this or maybe it could be this and the other comment as I read through this that jumps out at me is even in the last 3 months, the features and products of AI companies and technologies are merging quite heavily. So back to the comment around, some of those ambient dictation capabilities now are including revenue cycle and different types of automation and clinical decision support. So this space is moving so fast. When I read that application list, I don't think they're aware of some of those capabilities. So I do think that maybe we could play a role in helping to navigate through this. I think it could be both and not just this or.
Chris, I think that's a really important distinction. And Dick, I think you were touching on it too. I sat on a meeting right before this with one of our Kansas providers who is looking at automation in the revenue cycle. And they were looking at how do I automate my very existing process? So where can I, as opposed to saying, how do I completely rethink this process and take the manual effort out of it and really get from eligibility to procedure much faster or registration. And so I see that being something that all of you have great visibility to what's possible and being able to provide that insight and bringing along the rest of our providers to say, here's where this can take us and what those advancements look like and make those recommendations from a very informed point of view.
Okay, so both and approach. That sounds good. Any other thoughts about the committee's role for these funds in year 2? One thing we did want to note is that for the use cases, there's funding available to address the use cases that you all discussed earlier to prioritize in year 3, but not in year 2. And so if there's some interest in working on that a little bit earlier, that could, a combined approach might be something you'd like to consider, but we can continue to think about that. And we have a couple meetings left before the end of October, so. Okay.
Until Friday.
You have till Friday, yes, that's right. Okay. Sorry about that.
No, sorry, but you're on
Sorry.
our budget due Friday. We have
Right.
to say what dollars we think should be pushed to ETC as opposed to saying we're the funding rules are on KDHE's budget, so we can be taking away from that. So we have to put our pitch in Friday. Sorry.
Okay.
I'm not rushing.
Is the ability for this group if they were to say both and?
It's not a lot of money.
Okay.
That's the issue. It's again, it's the.
So what would the ETC do to say, hey, these are the 3 or 4 areas that we want to focus on? Like at the end of the day, I think from my perspective, what gets the most money out to the rural communities? So it doesn't get kind of collected in some molasses in terms of not getting money out to the rural communities, whether it's physician practices or hospitals or clinics or what have you. Like if it's easier so that we can point to, we can at least say, hey, 10 providers or rural entities received funding through the individual applications. To me, that's a lot better than saying, hey, we use this case use model and we're not really sure how many actually benefited, I guess. Like, help me understand.
Okay, let me paint a picture, and I'm not advocating for this. I'm just trying to create a picture. Let's say let's just use prior authorization. If that's the use case, Kristen goes through the same process she's done for AHAP and for us on ambient AI and creates the criteria, the requirements, identifies vendors, say if you've got Meditech, it's this vendor, these vendors, if you've got this, it's that vendor. And then at that point, there's I guess an application cycle opens for providers and say, if you are interested in this product, throw your hat in the ring. And we're going to choose who gets the money based on objective criteria. We can score you on objective criteria. We're going to do FQHCs first. So if you're an FQHC, you get this many, you get this. And if your level of sophistication, that's going to be this. And your level of need is going to be that. But it's going to be criteria that you all have created. So it's not going to be a subjective read the application, score them down because they use punctuation poorly, none of that stuff, but just sort of a score. And then it's the amount of money available. If it's X millions of dollars, and we know how much the negotiated rate would be, then they're going to get that much money. Plus, help me on the implementation component of that.
So right now for Anchor Hospitals, we have built into that funding an implementation partner that will provide at the elbow support. Is it going to be a singular partner or multiple partners? We don't know that yet. It depends again on where each facility is in their current state assessment. So how much change management or operational support do they need? And then of the recommended implementation partners, who can meet those needs? So very similar to who's going to be the vendor. Ideally, we have vendors that are able to meet a huge piece of that need, and then we offer implementation support. So that can be part of that funding as well that goes into the overall bucket. The next piece to that is, as we talk about what ETC should be focusing on, we are going to be talking about what does that look like future state, and should we be looking at some of these areas to create shared services for the state to be able to take on that burden going forward, so it's not implementation partners. But right now for this next year, along with those that participate and we understand where they are, we will have implementation partners that are part of that funded pool to be able to provide at the elbow support on site for those teams that need it.
I guess let me add one thing, Sarah. I think we will know the size of the pie, and we will know how many slices we can get out of the pie given the amount of money available and the negotiated rates. The challenge is going to be, how do you decide who gets what slice, right? That goes to Terry's concern. That would put the burden on this committee to do that prioritization. But that's what you're going to be asked to do with the ambient AI. Mm-hmm. The lucky part of ambient AI is we probably will have a whole lot of pieces for that pie, but as you get to these more complex solutions, fewer pieces.
And it could be as you think through it, it comes back to who gets the funding right now and then who comes in wave 2. So while all that funding may not be available in that first year, how do we sequence it so that we are not creating greater disparity between the haves and the have-nots from the provider side?
So I would put a recommendation on the floor. If we have to choose an or for year 2, based on the conversation that we just had, I would recommend the use case model. And I think for a couple of reasons. The purpose of this program is to demonstrate improvement in viability and sustainability of rural healthcare year over year. If we fund individual applications that are in 72 different priority areas, we're not really making progress in some of the areas that RHTP has identified are necessary to sustain rural health. We know that that's, AI supported workflows. We've identified ambient listening for documentation. We've identified, I think, down the road some revenue cycle things. So I think you get a better evaluation of the program to build on from year to year if you align it with the use case model instead of what the individual providers, because they may not know the appropriate solution for whatever they're trying to solve, whereas we are trying to solve, I think collectively as a brain trust in this group, using technology to solve some of those sustainability and viability problems for rural health.
Right. So part of that is you may not get a piece of the pie, but you will be able to draw on the intelligence of this committee saying, oh, that's a good product.
So I like that idea, and maybe just a question really is there anything limiting us from also looking at maybe year 3? Because one thing that as year 1 and year 2, that as I think about what's proposed, individual applications or what we're talking about, one key component that I don't see is, as a patient in state of Kansas, like I don't see anything for the patient perspective. So I think about there's a lot of AI assisted triage and patient navigation and coding that, I feel like we need to at least have that in the next 3-year roadmap. Doesn't have to be year 2. I said there's a box that was limited, but you know, if I was a patient of state of Kansas, I'd be asking like, what's in it for me? Because these are all going to providers, which is great, but how do we maybe carve out a component from an AI capability that there's a lot of you know, already tools that are available, like, you know, AI assisted triaging that, you know, it's pretty low cost entry to, you know, standardize. That's what I was meaning is what are some of the AI, you know, starter pack for the patients that we could also be maybe advocating as a use case as well.
Great idea. And I think we could even say for year 3, that becomes one of our next meetings, is that we talk through what are all of those next use cases we really want to focus on, and do we bring it up as consumer focused versus clinical or operational focused, and start to prioritize those. Because before you know it, this group is going to be asked to come up with year 3 budgets and knowing what that starts to look like in buildings sooner will help.
That's due next month.
Yeah. So thinking about, there's been some different discussions, some different opinions. Do you think we can get to consensus on, knowing that the budget has to be submitted Friday, what direction the group wants to go? Thumbs up for use case approach, or thumbs up for a hybrid approach?
I don't know if this plays into that question at all, but if, as we're deciding, is there something we should consider about the way the budget is split? I think, Marty, you were getting this when you talked about the pieces of the pie being split up, but instead of Liz saying, gosh, I really want to do this project, it looks like I can request $1 million to do it. Okay, I'll request $1 million. Could I do it with 500,000? Maybe, or is there a more equality, like to get this project done, everybody's going to apply for an equal amount, because we as the committee have looked at how much is required to implement that thing. Or if Liz decides, I really want this other product I'm looking at that solves the same problem, it costs more, I still only get a base level amount, and then I have to fund the part that's on top of for my extra special thing that I wanted. Does that play into how we allocate the budget?
Decision.
Yeah.
Either here's your turnkey solution, it costs this much, you're getting this much money, you're getting that solution, or here's your budget to implement a solution you're gonna have to kick some money into. That's part of what you all be thinking about.
Yeah. So I think the decision on the table is still for year 2. Would the committee like to provide direction based on the use case model and request that the money currently allocated for the grant program shifts to that approach? Or still retain some individual application grant program dollars and recommend the key areas that those dollars should be allocated toward? Or something else?
How are those two?
So the first use case model would be, you've identified those 2 use case priorities, and we would go through the same process with Kristen and her team support, like we've done for ambient AI. So that RFP would be developed with their criteria. If you just recommend, hey, I think KDHE, you work on revenue cycle and prior authorization, they're going to run that process, and individuals will apply through that same process that they did in year 1.
I think the main difference here would be, where does that budget lie? Does it lie with the committee and we're making decisions about, or you all are making decisions about where that's going? Or are you all just providing, or not just, but are you all providing advice or direction to KDHE on how they're going to kind of collectively? Yeah.
Yeah.
Gotcha.
So what do you?
Love your thoughts now that you've differentiated it.
I I tend to be in the camp of the use case model, kind of what we're doing with the ambient listening. And I think really for some of the evaluation and future planning that we're going to be asked to do as a result of it, I don't know definitively that we couldn't still get to that information through the KDHE advising model. But
You agree? Okay. Any other, so we're leaning toward use case model unless we have any objections. Terry, you had a thought about potential conflict of interest. Now learning about how the funding will be used, do you have those same concerns?
No, when I stated that, I was thinking that this committee would determine who got money.
Oh, I see.
So, yeah, so I back off.
Okay, great.
Thanks.
All right. Okay. I think we'll go with that. Marty, good? Others?
I don't want false
Yeah.
consensus. People really have.
Yeah.
concerns.
True.
I just think it's, sometimes money goes to whoever has the best grant writer, to be honest. And a lot of these rural hospitals don't have really good grant writers or don't have that resource. So I like how the Anchor Hospital program was defined, clear criteria, clear product. It seems like this is similar to that. It's kind of what
You do realize you're buying yourself a lot more work, right?
Yeah.
never mind.
More capacity. Yeah.
Just thinking about the politics, which I think should be taken into consideration. I mean, could there be a percentage of that allocation that remains in the individual applications? To at least defer some of that, and those who are really reaching high would have the ability to do so, but you wouldn't cut it off stark.
I think that speaks to, Chad.
Yeah, I think one option, James, would be the committee would cross that bridge when it got to it. If you said, we want to allocate we want the 10 million to allocate. And as you're working through the use cases, saying, hey, we actually want some folks to go out and do some wild, crazy stuff and try some cool new stuff. And so we're going to have funds for that. Or we know we have hospitals that are crashing, so we want to have a fund to bring them up to at least, lights on.
I like Sarah's comment before about we're trying to make this transformative across the entire state of Kansas. Everybody's going to benefit from it. However, I agree with Chad though. Hospitals are asking when they come to me is like, how's this money getting to me as a facility? I think that's the kind of the question he was maybe getting at. And if there's a better way to quantify that to say, how is this money getting to those individual facilities or how's it benefiting those individual facilities would be one way to make sure that it is fair and it is being applied appropriately.
So 2 really quick thoughts. One, I think as you go through the ambient listening, whether it's for the Oracle or the non-Oracle, we will be able to very clearly identify where the funding is going. Same thing for evidence-based practices, the remote patient monitoring. So at the end of maybe not year 1, but definitely by the end of year 2 or halfway through, we should be able to very clearly identify how many independent providers and facilities have benefited from the dollars. And I think the other piece is this current state assessment that we've talked about that's going to walk across all these work streams is going to give you all a depth of information on who are those facilities that may not be eligible for any of these use cases because they are so far behind. And that becomes the discretion of this. Alan, you brought it up. How do we use those dollars for use cases that could potentially be a use case of bringing those facilities up to where they can benefit from the dollars in future years? But just as you think about coming back to having transformational impact, I also think it is closing that disparity gap of what is available today to be able to provide care from a sustainable manner. And so it's really being able to measure both sides of that.
Regarding, I just want to hear from somebody else though.
Yeah.
Between the 2 options, Scott or Chad, because you represent so many different facilities in your constituency, what do you guys think about those two options and argue both sides so we can help make that decision for the rest of us?
I see the benefit of both sides. I love the fact that you're transforming care as a whole. I mean, and that's something healthcare is needed forever. So why not that's a great goal that we should be trying to accomplish. But at the same time, I know a lot of those facilities have come to me and asked, how do we know that money's getting to us? How do I how do I get a part of this pie? And that's why you have 72 applications for emerging technology grants too. And when you can say, this money went to this hospital for this purpose right here, it's a lot easier to defend, I guess, too. So I see both sides, and it's tough because I love to be innovative in what we try and do, but I want to prove that we're providing value to them too. And they're getting, I mean, Alicia, you're one of those hospitals that we try to help represent. So.
Maybe kind of, Chris, maybe this is where you're getting at is, like ambient dictation can be rolled out in a way that's not just the hospital facility that licensed that, but individual providers can do it and doesn't have to integrate into specific EMR either. You can still get a tremendous efficiency gain by just using it as a provider, independent, provider groups or physician, just to have it on your phone and use that. So I do think, again, I'm making this up, but let's say we select a vendor and we negotiate as a statewide initiative, a price point that's really attractive for individual hospitals, they can even roll it out, or individual practice could even load it. So that's where I do think that, I even have a provider, when we piloted 5 years ago, they're like, if you stop paying for this, I will pay out of my pocket to get this technology, right? So again, I do think we can tell that story of, here's how we're approaching it, transformative, but individual rollout, individual doctor can't even purchase it under this purchase agreement, whatever that looks like. So I think there's a lot of ways we can kind of tackle maybe, multiple ways of meeting the needs of the rural provider at an individual level, but also have a statewide initiative to say this is going to be transformative for our providers.
And so for the use case model, I guess I was taking that to mean a particular use case, not a particular vendor. Is that what others are thinking as well? Okay, just want to make sure we're on the same page. So it still allows quite a bit of flexibility for the organizations to pursue different avenues of a particular use case. But I think if you get down to individual applications and you just open it up for everything, I think it's going to be difficult to track and difficult to manage, honestly. So I would favor the use case model personally.
I made a couple comments, obviously, and from my perspective.
You got it.
As Scott mentioned, I see both ways and benefits, and when you take a step back, so where I'm sitting from is that Kansas got $222 million. We have 104, 105 rural hospitals. We have all these rural health clinics. We have FQHCs, community mental health centers, and what have you. And, there's only so many places where they can individually plug in and get funding, because early on, I think they felt as though that, they were going to get direct checks, and that obviously was, taken off the table and not something that was permissible. And so they can get funding through the regional partnership grants. They can get funding through the capital improvement grants. I'm assuming those are going to continue for year 2. And then the EB, the enhanced, the quality metrics, EBT, evidence-based practice, they can kind of tap in there. I see the transformation, and we want to be transformative and what have you, and I'm comfortable if we want to go down that approach. I just don't want to be at a point in time where we don't have abilities for individual entities to be able to access some of these grants, because they are looking at ways as to how can I access these funding opportunities, because I have something that I believe is real strongly in my community, and I want to be able to tap into some of the hundreds of millions of dollars of resources that are being made available. So that's just kind of my perspective that I'm coming from. The use case model, but just make sure that we look at the other funding opportunities in other areas for individual providers.
And in terms of our obligation and for the grant overall, and I think this is perhaps KDHE's obligation, we have to prove that these funds are used meaningfully and have a result, if I'm not mistaken, in order to get the additional funds on a continual basis. So again, that's where I think the individual applications would be extremely challenging for you to track down the impact that each one is having and be able to then get continuation of funds.
If you talk to folks that have got these scholarships, you are hopeless. One of the challenges with the individual grants is that they are subrecipients, since they are going through the subrecipient process and they're at wit's end over that. This would not be looking like that. You're living that, aren't you? Another piece of this is, if you remember regional partnership, there was an exclusion for technology. They're going to take that out next year, or at least that's the plan. So that's also another avenue for folks that have technology. I mean, they certainly would have to still be regionalized, but it still gives them another option.
I think it also opens up a bigger conversation that we started with about engaging those constituents and all of those individual providers across the state. So while right now it's a current state assessment, if they have really unique needs that we aren't hearing, that's a problem. And so how do we start to create that ability to engage and have that outreach to hear if they really are having problems that are not addressed by the use cases that are being prioritized, and how do we start to bring that voice forward?
All right, any final thoughts about the approach? I think I'm hearing we're leaning towards use case models, but there's a lot of details to be worked out. You want to go ahead and vote? Okay. Show of hands. Who is in favor of requesting the allocation for funding in year 2 to work on use case model approach?
That's option 2.
Option 2.
Option 2 is to.
Which one were we just voting on?
You get the 10 million or KDHE gets.
Yeah, basically, you get 10 million to dictate to work on use cases, or KDHE gets it, and you could provide input into that process somehow.
Yeah. I'm getting good at it. One skill I have developed is avoiding subrecipient.
Right now, the paperwork is overwhelming. So I can tell you, to try and get everything through, it's just overwhelming. You need FTEs just to do that. So.
Yeah. Contractor agreement.
Yeah, a contractor versus sub. Yeah.
Opposed to buying a program.
Yeah.
Okay.
Yeah, they wouldn't be.
Hours and do charts if you'd like, Sarah.
No. It just was work for us.
I just want to know for future reference on things I might be doing. Not in this work, but in other areas.
We can have a whole, we can have a whole workshop on the difference between contracts and subs. Okay, for those online, we'll just ask you to raise your hand. Use the raise your hand feature. Okay. So on the table is the approach for using an allocated amount of money in year 2 to either work on identified use cases as an ETC, so developing the RFPs associated with those 2 use cases and determining the funding, or to support the existing KDHE grant program in year 1 that would continue in year 2 without the funding. So do you want the money, or do you want to not have the money, I guess? Okay. Raise your hand for use case funding approach. 1, 2.
Keep the money.
Keep the money. Online, who do we see? Vote for use cases. Use cases. I think we have consensus. Okay.
I'd like an in. Does that look like an in?
It was not unanimous. It was a majority, not unanimous. Okay. Anyone have any strong feelings like, hey, absolutely not? Okay. Mike, the question is, can you avoid subrecipient if KDHE
In the other model.
in the other
that we
model?
Didn't vote for. Not that it matters because we voted for it, but.
Fiscal agent taken the position that KDHE is awarding a grant to an individual entity. It constitutes a subrecipient arrangement. The dollars lose their federal identity at the point that there's a contractor agreement as opposed to a subrecipient agreement. So for example, in EBP, you are not subrecipients, you're just contractors. And so you just get the check. You do have to sign the federal terms, but there's not the requirements of an SRA.
So that way seems much simpler.
So try this. There's no cup around right now. Scott, did you have to sign a subrecipient agreement to get the money for Oracle?
Yes.
A subrecipient agreement?
No, you got it.
That's it, yes.
We will have your contract. You say, we'll deliver X. Yeah. No, you did not sign a subrecipient. They were the subrecipient, CAA.
Yes. BDO approved that.
Yep.
Is that a good thing for all that?
Damn.
Yeah.
Yeah, all we have to do is provide like monthly, quarterly updates on how we're performing. That's it. So it's straightforward for us and we have the reports already.
Andrew, did you have a comment?
I was sort of forced the microphone by Liz, who wanted me to speak up since I was a holdout. No, I'd say I wasn't an absolutely no. It was going back to my original comment around being thoughtful. And we talked a little bit about having funds set aside for providers who may need an extra push to get to wherever it is in one of these use cases. The only reason I didn't vote yes was because I have not seen the result of the existing grant program and how successful it was versus this model. So without that evidence, I think hypothetically, so that was the holdout.
Makes sense.
Yeah, there's nothing like budgeting year two, not having any idea if year one worked. That's where we are.
As we say use case, I know I'm not going to even look at Sheena because she's going to tell me to quit talking right now. But as we look at and we say use case allocation, I don't believe that we're saying it's limited to those two use cases that we've identified as of right now. That is, we get back that current state assessment and we see that there is something else that really needs to be involved in that. Is there a reason that we can't? We're still saying it is set aside for use cases that this group identifies as the priority, with the opportunity to potentially shift within those that were identified, correct?
Do what James talked about, having a portion.
That's set aside for those that are not. Yeah, okay, fantastic.
Okay, all right. Sounds good. Okay, we're gonna have some time to continue talking about this in small groups. So we had identified, just based on previous meetings and conversations, we've done a lot of talking about what is already kind of baked in and potential opportunities around this budget for year two. There's some additional things that the committee has identified that has popped up during previous conversations that we thought that could be potential additional activities to consider in year two. One of those being guidance, standards, and best practices for IT and tech governance, development of centralized IT and shared services, providing input on other related RHTP programs, like the crosswalk that we went through at the beginning of the meeting, or other ideas. Knowing that we have a limited number of meetings and there's would be increased capacity around the use case application and in taking that budget on in year two, in addition to year three. We were going to ask you to prioritize one of these that we could potentially include in year two as as a task. It might just look like, hey, we want to start looking at this for year 3. But we want to go ahead and have you do another mentee. And if you had to choose one, what would it be? Or is it still an allocated points? Yeah, so what do you want to put your points in? Just allocate your points and see what comes to the top. Oh, right.
And just as a reminder, the emerging technology grant use case implementation that we've just been discussing, that's the 4th option. Yeah. So it's included here.
And as we talk through guidance, standards, and best practices, that has come up multiple times in the meetings. It is, do we start to create that standard set of, here's our standards for cybersecurity, for AI implementation? And I know that several of you have said we have some best practices to share, and really use this group to say, what does that start to look like, so we can use those for any future implementations as well.
Thanks, Kristen. Michelle? All right. So it looks like pretty even. So that's a good to know that maybe if we don't work on it next year, all of these are resonating with folks. But guidance, standards, and best practices for IT, along with our emerging technology use case implementation, was ranked the highest. All right. So thank you for that. Now what we're going to do is move on to our exercise. So we'll spend the rest of our time together kind of working through what some of these things might look like. Here you go. All right, so in your packets, you have work plan development. There's a note taker. And at your tables, what you're going to be doing is to review the set of potential focus areas for the year 2 ETC work plan. Each of us will be at your tables to help record your conversation. So what we've done with the poll just now is that we narrowed the list to a shorter set of priority topics. So what you're going to do is we're going to give you the 4 groups, and then you'll self-select into the group that you want to work on. What you're going to be working on together is to kind of game out what that's going to look like in year 2 and beyond. And also, if you have questions, considerations, we'll put some white paper again on the walls. If you have key challenges you want to talk with the group about, you'll work through that on your table, and then we'll have some time at the end to share as a group for common themes and approaches. So Wyatt is going to share what the 4 groups are, and then you'll have an opportunity to kind of get up and move around.
Yeah, and just a little more information. So we want you to start with your note taker. We want you to get your individual ideas down. We want to make sure we hear from everyone. We're going to take those so we get your feedback. So we know sometimes it's hard to everyone to have a chance to talk, but you're going to start with that, make some progress on thinking through this, and then you'll work as a table. So one of the tables, and we'll make it this table here, is going to be that first use case. So the first use case you picked was denial prediction and management. So if you want to work on thinking through what would it look like to make progress on that as an ETC, come to this table. The next group is the second use case, and we'll make that here the prior authorization. So if you want to wrestle with prior authorization and think through what are some activities within that and building out with the known that both of those use cases are going towards an RFP deliverable, but think through what do we want to prioritize? What sub activities? What are some bounds? What are some focuses? What are ways we'll know we're successful? We want you to help us make progress on that activity with an eye towards we're working on this in year 2. The other 2 areas, we just had a lot of conversation about the role in the use case work with Emerging Technologies Grant Program. So you get to continue that conversation at this back table. If you want to think about what was the ETC or the Emerging Technology Grant that's now this use case, what form does that take with that additional 10 million? So you got to keep working on that. And then the last one is the topic that was just prioritized, which was those standards for IT and guidance. So this group could make some standards, some guidance for IT and share that out across the state. What would that look like? That's maybe the one we've thought about the least. So if you're ready to be creative and think about.
Wyatt, so the use case funding model, they're going to be talking about those 2 use cases and how they would implement that on the other 2 groups. So we'll do the other 2 tables for the other 2 topics. Which one? Yeah.
I was just going to ask how is the funding different than the use cases?
It's not different. So that's what I'm saying. We're taking that off the table and we'll do the other 2.
Okay.
Sorry about that. We're just trying to update in real time. Okay, so the other ones are guidance,
centralized workforce, and setting standards and governance.
Okay. My apologies for the lack of clarity. So over here, use case 1, that far table where Andrew is sitting, that's the denial. So if you're interested in denial prediction and management, you can move over here. Hopefully we have some. Second use case. The second use case, which is where Dick is, and he sounds like maybe he's going to stay here, is the prior authorization use case. So if you want to wrestle with that, so feel free to stand up and start moving. And then back here, we have Sheena's moving it.
guidance, standards, and governance, and development of centralized IT shared services. You don't have to stay at the table that you're at. You can can move around to the table that you want to discuss.
Move to where you want to go.
And then online, you can choose one of those 4 areas to work on. So the choices are use case 1, use case 2, guidance and standards, and centralized IT and shared services. And we have, you'll be sent into a breakout room to discuss, and you'll have your own facilitator online. All right, we want to make sure we can keep our promise and get you guys out of here by 4. So let's wrap up our conversations. We'll have a few minutes for sharing out.
Now we got it there for you. Now you that's a road. I think it's all slides. So I said the operation. I need I think yours are. How do we have or you know, or you have something else. How much of this? What are your
All right. Please wrap up your conversations and we'll get back together.
Can you come to my group class?
Yeah. All right, I think we'll switch it up this time for sharing out. Those online that were able to, have conversations, which area did you pick and would you like to talk through the approach that you came up with for year 2 work plan?
Yeah, this is Robert.
Hi, Robert.
So we talked about the IT standards. So I guess number 4. So there's a lot of different things we discussed, kind of the highlights in terms of the potential for developing standards. Some of the different areas we looked at. One of those was related actually to like group purchasing. So in terms of standards of like software and hardware, things like that, providing some guidance on suggestions, especially to more rural facilities that don't have even sometimes dedicated IT staff. So one of the things we looked at was establishing IS user groups. So some mechanism for smaller facilities to work with people from larger facilities, specifically related to IT. So just a forum, if you will, for people to get guidance on sometimes software, hardware, or just, anything IS related, to bring some of those people, the expertise we have, people that are more in the larger cities to more of the rural folks. And then in terms of other policies, cybersecurity policies, auditing and data governance policies, and then one that we think is a big one, which is obviously a newer one, but AI governance, especially for some of the facilities that don't have the staff to vet AI solutions, things like that. Those were kind of the highlights from what we came up with as far as the IT standards.
Thank you so much, Robert. And I'll go back to the similar group that also discussed the standards and guidance. What were some key activities that you noted and any considerations for those?
We had comments really along the same lines as Robert, although we did think the guidance could apply both at the committee level as a whole and then to the participating entities that might receive funding or other outputs from this group. There were a lot of comments about issuing guidance around regulatory concerns, HIPAA, interoperability with FHIR, or API compliance. We talked a little bit about transparency and consent policies for entities, along with requirements for vendors that might be incorporated, both again at the committee level and then available as templatized clauses that they could put in vendor agreements and that type of thing.
Thank you. Okay. One other thing I think the group noted was to collect some information to inform the guidance, either from Kansas organizations that are implementing this, but also maybe in other areas. And also making sure that it's resonating with community providers. Is it actually going to help them? What guidance do they need, or what are they looking for? All right, so I think we'll move to this table. What did you all work on?
We had the development of centralized IT or shared services. After we got done complaining about it for a while, Chris came over and sat by our table and gave us a little more guidance. No, Chris did a good job of introducing what the Indiana model is. If you want to talk about that a little bit.
Yeah, so what we're not proposing is the idea of pulling together all rural health, hospital IT and team into a one team. That's not what we're proposing. The concept is really, so state of Indiana, on the university and border region side, recognize they just didn't have the skill set or enough critical mass of IT professionals to really reach a level of maturity from cybersecurity. So what they did is, as a state initiative, it was that they started I believe it was a non-profit group that it's partially student manned. So you pull resources from all of the different parts of public education and university institutions, and it becomes a workforce training ground for these institutions while you man with specific information security professionals. And really, it's a workforce readiness plus using that to supplement what those rural universities or hospital in this case could be, leveraging. So typically, cybersecurity happens over holidays and evening, and so what Indiana started with is a security operations center that it's 24/7 man with student and professionals to be able to respond whenever rural clinic or hospital gets ransomed. They know who to phone, they know who to go to, and really kind of building out that operations center for the state that rural IT or hospital can tap into as a resource. And you can start to then drive those, standardization around different technologies like firewalls as well, because obviously you can't have 25 different firewall to support. So then those that want to be part of it can start to kind of standardize to what that standard needs to be, and also lowers the price point for your because you can negotiate as a state, to man this SOC through this program, a statewide, pricing point to really maximize the value as well. And so there's a lot of different way to approach it, but really, again, the goal isn't to centralize all rural health provider IT into a single team, but standing up these types of institutions that can supplement where those rural providers just don't have the manpower to get to.
And I think on top of that, you also brought up about how all the universities or community colleges that have informatics programs as well, could this follow along the same lines of have the informatics students help staff a at the elbow support or virtual at the elbow support after the vendors have trained them on maybe an ambient rollout for all these individual providers, and they can help with the change management and navigating through all those different pieces of a major project like that, or the other major projects we continue to talk about from emerging technology.
Yeah, so we call that trainer model, where I know in that table we were talking about, when you do the needs assessment, if you don't have the team that rolls out implementation that really doesn't understand rural providers or how things are done, you have to retrain these, vendors that comes in again. And so again, you really save dollar and efficiency when you have a team that's dedicated. So the idea is that maybe through this kind of a service provider group, that implementation resource could be year 2, 3, where we hire a vendor to train this implementation group, so then they can continue that, not only first 2 years, but post 5-year implementation. So we have a group that can help rural providers to do change management, document the current state, and so that we can kind of do it as a standard program.
So, yeah, I had a question, really. I mean, I think that idea is great. I mean, I have a whole bunch of other questions that can shoot holes into the theory really quickly. But the main thing is wouldn't this also rely on everybody having the exact same setup, which is almost next to impossible?
Yeah, and that is one of the things we work towards. Standardization would be the key. It isn't necessarily everybody has to be perfectly the same, ideally, standardize a lot of the processes and equipment and everything else would be ideal. But yeah, the informaticist having to navigate change management for one facility could be completely different for another one, 100%. And I think just helping to drive some of the standardization of what works in industry or what's been seen to work possibly.
All right, thank you so much. I think we have just a few minutes left to talk about use cases. So we'll go to automating prior authorization. What activities did you all discuss?
Well, who's this?
You got this.
Sarah.
What did I do? I didn't make any notes. Not a single note.
That's all right.
Oh,
Oh, Shelby. Yep.
yes.
Okay. Shelby's got.
Alrighty. I'm coming to the rescue. Alrighty. So we had a really fascinating discussion about prior authorizations. Once we kind of got through some of the background discussion, some of the key, it was so good though. So I thank you so much, Dick, for bringing all that to the table. Some of the key activities that we identified, one was getting information on what tools and capabilities facilities have on the front end. So thinking through how did they get the demographic information, coverage information, things like that, that kind of currently slowed down the prior authorization process. Another thing we talked about was who needs to be consulted. It's on. I don't know if it's working. Is it not working? Okay, perfect. Alrighty, so who needs to be consulted? We had payers, clinicians, physicians, billing, contract management, front office, registration, scheduling, as well as health information management, I believe. With this particular use case, the timeline is kind of already built in. It follows the process that we're seeing with the ambient AI system. It's just in year 2, so we didn't spend too much time there. In terms of measuring success, the ideal would be to get prior authorizations done in real time, and at minimum, reducing the time it takes for patients to get those prior authorizations addressed. And we did include that this would cover a wide variety of services, including surgeries, procedures, diagnostics, prescriptions, and any other testing.
Okay, thank you. And Kristen, your group.
So I would say we were on the same path, and actually we just kind of condensed the 2 use cases into one. And we put some brief timing up there to just say that Q1, it's really mapping that entire process. So from how you capture that information all the way through to the collections, and then identify what are those most common areas of need or where it's breaking down in the process using the data that is available, but also through those conversations in the mapping process. Then it's further refining what exactly are those use cases that we're going to solve for in the revenue cycle. So is it eligibility and prior auth, or what are the pieces that we said are those most common points of need? Going into QT, then our Q2, defining the requirements on those defined use cases and following that entire RFP process. The one piece we added in will be using the new standards that are being defined by the other as we go through this process of what do we want to start building as those standards for how we operate in IT or partners. And then getting in by beginning of Q3, being able to select who those vendor partners are, and who is eligible in the application process for the funding against those use cases.
Okay, that's a lot. We got a lot done today. Thank you so much for your continued engagement, your thoughtful approach to these big questions. We really appreciate it. Any other thoughts, questions, ideas? We do. We have a collective vision we brought together. It's not fully formed yet, but let me see. Will you bring it up on the... Oh, I have it. Sorry. Oh, it's hidden. Okay. I can unhide it. Okay. One moment, sorry. Okay, all right, here's a couple of options we workshopped during the break. One is that Kansas providers, regardless of size or location, share a common technology foundation that keeps patients connected to care and closes the gaps between them. The ETC guides this work, vetting new tools so they earn trust and before adoption. The result is a fully connected system serving every patient everywhere in Kansas. Another one is the Emerging Technology Committee guides Kansas providers, regardless of size or location, toward a common technology foundation that keeps patients connected to care and closes gaps between them, vetting new tools so they earn trust. And the result is a fully connected system serving every patient in Kansas. So it will be, how does that general direction sound? We still need to workshop it, wordsmith it. It's an accurate reflection of discussion. Okay. All right. Okay, any other thoughts before we depart today? Thank you so much for showing up in person, dedicating a half day of your time. It does take a lot of commitment. We truly appreciate it. And thank you for letting us facilitate your conversation today. Oh.
This level of talent together. Already spent 6 hours of the another 4 hours here, and I know there's lots of work going on outside the time you're spending. It is so very much appreciated. You are rock stars, and we're going to be making such a difference. So thank you very much.
If you are willing, please leave any notes you took that you want us to include as we refine this. We're going to be taking all these notes. We wrote it all down so we can use it and keep facilitating. So if you're willing to leave your notes, if they weren't something you feel like you have to hold on to, we will take them and we will include them in our summary and our work. So feel free to leave your note takers or your vision documents.
Safe travels.
Yeah, that's right. Tip your servers and bartenders.